السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.
أوكي. بسم الله الرحمن الرحيم، والصلاة والسلام على رسولنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أما بعد، تحت رعاية رئيس جامعة الإمام عبد الرحمن بن فيصل الأستاذ الدكتور عبد الله ربيش، وسعادة عميد كلية العلوم الطبية التطبيقية الأستاذ الدكتور قاسم المعيدي، وسعادة عميدة التعليم الإلكتروني والتعلم عن بعد الدكتورة منيرة المهاشير، محدثتكم الدكتورة نور الختلان رئيسة قسم الرعاية التنفسية بكلية العلوم الطبية التطبيقية جامعة الإمام عبد الرحمن بن فيصل، ورئيسة اللجنة العلمية للملتقى الافتراضي الأول لقسم الرعاية التنفسية بالتعاون مع منصة طب إكس التابعة لعمادة التعليم الإلكتروني والتعلم عن بعد. ونرحب بكم في ملتقانا الافتراضي الأول المتعلق بأحدث المستجدات في مجال الرعاية التنفسية أثناء جائحة كورونا. من هذا المنبر أود أن أشكر شركائنا في النجاح من زملاء وزميلات على الصعيدين المهني والعلمي، من المتحدثين ومدراء الجلسات وجميع المشاركين، وكذلك الرعاة لهذا الملتقى عمادة التعليم الإلكتروني والتعلم عن بعد وشركة ثمار الجزيرة فايتال إير لرعايتها لهذا المؤتمر. فلكم منا جزيل الشكر والتقدير ولحضوركم الكريم، ونتمنى لكم وقتا مفيدا زاخرا بالعلم، ونرجو من الله عز وجل أن يرفع عنا وعنكم وعن بلادنا البلاء والوباء، وأن يمن علينا وعليكم بالصحة والعافية. كما أود أن أنوه للحضور بأن الشهادات والCME Awards لن تمنح إلا لمن يحضر 70% على الأقل من هذا المؤتمر الافتراضي. I would like also to translate this talk in English to non-Arabic speaker from the audience. Under the patronage of His Excellency, the President of Imam Abd Rahman bin Faisal University, Professor Abdullah Rabish, and the Dean of College of Applied Medical Sciences, Prof. Qasim Al-Maidi, and the Dean of of E-Learning and Distance Learning, Dr. Munira Al-Mahashir, dear speakers, colleagues, and guests. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to welcome you all to the Respiratory Care webinar meeting, Hot Topics in Respiratory Care during COVID-19, in collaboration with TEPEX platform of the Deanship of E-Learning and Distance Learning. Also, I would like to thank all sponsors for this forum, Thimar Al Jazeera and Vital Air, and Deanship of Scientific Research of E-Learning and Distance Learning, and wish you a useful time and that's full of knowledge. And I would like to acknowledge that the CME hours and the attendance certificate will not be awarded unless you attended 70% of the online webinar and sign and answer all the surveys. Thank you very much. First of all, I would like to welcome Professor Hatem Qutb. Professor Hatem Qutb, he is the Professor of Pulmonary and Critical Care Medicine at King Fahd University Hospital in Al-Khobar. He was the Dean of the College of Medicine at King Faisal University Al-Hassa, and the Department Head of Pulmonary Department at Imam Abd Rahman bin Faisal University, King Fahd University Hospital. Professor Hatem published a number over 59 papers in national and international journals, and he will be the moderator for this session. So welcome, Professor Hatem, and you can start.
جزاك الله خير دكتورة. بسم الله الرحمن الرحيم والصلاة والسلام على المرسلين سيدنا محمد أجمعين. Good evening, and I would like to thank the Department of Respiratory Care at our university, Imam Abd Rahman, for taking this lead. And this is not surprising. This is our annual CCR, and the department are holding such issue in this time allotted during the pandemic of almost 1 year for the kingdom to carry on. I also would like to mention that our partner in looking after critical ill patients, the members and the colleagues from the Department of Respiratory Care, are very important about, and they did share a lot of responsibility with us. And I'm pretty sure, as intensivists and pulmonologists, without their support and help, we cannot reach to this kind of care. We have diversity of presentation, and we'll be honored to have Dr. Abdullah Al-Anizi. Dr. Abdullah Al-Anizi, he's assistant professor at the King Saud Abdul Aziz University Health Science in Riyadh. He's in Department of Respiratory Care. He's a pioneer in his field, and he obtained a lot of SIFRA reward on different national and international bodies, including from 2018, 19, and 20. And I'm pretty sure all of us were going to hear about the the era which is happening during the COVID crisis, the use of high flow nasal cannula, which has been in the market for quite some time. But when the COVID crisis come on board and the transmission was of an issue, the high flow nasal cannula becoming very, very known and used by the RT and the intensive care unit. So without doing the time, in this coming 20 minutes, we're going to enjoy the presentation of high flow nasal cannula, review of the clinical performance and recommendation. Dr. Muhammad, the floor is yours.
دكتور عبد الله دكتور حاتم.
Dr. Abdullah, sorry.
السلام عليكم. Thank you, Prof. Hatem and Dr. Noor for your invitation, for your also welcoming remarks. I'm glad today that I'm going to share and review some clinical performance and recommendation of high flow nasal cannula to my colleagues and to my fellows. I am Abdullah Mayouf Al-Anizi. I am assistant professor in the Department of Respiratory Therapy at College of Applied Medical Sciences, King Saud bin Aziz University in Riyadh, and Ministry of National Guard. First, high flow nasal cannula, as Professor Hatem introduced, that it gained a lot of momentum in the past year, especially with the pandemic of COVID-19. COVID-19 was so tricky that with the shortage of production of mechanical ventilation and the supply and demand of mechanical ventilators, high flow nasal cannula made its way as a reservoir and as a spare to produce oxygen supplement and to provide the demand of respiratory supplement and oxygen supplement to those patients in need. Therefore, today I'm gonna take just a brief background about the invention and mechanism of action of high flow nasal cannula. I'll introduce briefly about the use of high flow nasal cannula in neonatal pediatrics, because our colleagues in pediatrics are pioneers in using high flow nasal cannula with their little patients. Also, I'm going to introduce high flow nasal cannula use in the pre-COVID-19 era. Then I will talk extensively about the use of high flow nasal cannula post-COVID-19 era. So with respect to innovation and invention, high flow nasal cannula, it's from the name of it, it's based on the nasal cannula. So we as a respiratory therapists and the clinicians, when there is a demand of oxygen supplement to our patient, we start our first line of support is nasal cannula. Nasal cannula provide very low FiO2 with low flow. So coming from the wall, oxygen comes pure to the nasal cannula, and with the mixture with the environment and room air, the dilution of pure oxygen will be diluted to low FiO2. And whenever we give a flow from, like, let's say 4 to 5, 6 liters, that gas gets very dry and will dry our airway mucosa. Therefore, when in the invention itself, it introduced to use bubble humidifier with nasal cannula. And this humidifier has certain limitation, so we cannot exceed certain flow. This is what came to the idea that why we didn't use high flow with nasal cannula, in addition using humidity and heated humidifiers. So this invention was first introduced as historical perspective from nasal cannula using bubble humidifier, then as a heated nasal cannula with high flow, reaching the inspiratory demand. You and I, our inspiratory demand is around 40 to 60 liters per minute. If we are really in high work for breathing, we may reach to 80 liters per minute. High flow nasal cannula, on the other hand, can provide up to 40 or 60 liters per minute. So technically, high flow nasal cannula with its simple connection can meet or exceed the demand of the patients. Looking at the invention itself, so we can see that the high flow nasal cannula relies on the use of Venturi principle, and Venturi principle relies on the air entrainment theory, that we can entrain the air from the environment based on the inspiratory demand of our patient. So technically, if you use like Venturi mask, it's the same concept applied with the humidifier in the high flow nasal cannula. This invention itself, it was really accumulated and it was really assembled together in Europe, and it was filed 2005 to use among adults. So if you want to read the instruction and the details how high flow nasal cannula was engineered from its physics, I highly recommend reading the patents of each device you want to read about, or you want to know about the physics and the instruction of that device. For example, here, high flow nasal cannula. Mechanism of action. So the high flow nasal cannula rely on the gas conditioning effect, meaning that the gases that we inhale rely massively on the exchange of humidity and heat, meaning that when we breathe pure or dry oxygen or from our upper airway, the upper anatomy will exchange this heat and moisture with our airway mucosa down until our alveoli. Here, the mechanism of action with the high flow nasal cannula apply the same concept of upper airway using heating and humidifying effect of gases to warm up the airway mucosa with the supplement of humidification to reach the alveoli with humid and heated gas. Also, it improves the mechanism of heat and humidity to increase the compliance and conductance of gases. So one of the advantages of using high flow nasal cannula, the compliance rate is very high with high flow nasal cannula, meaning that patient can tolerate using high flow with bronze in their nose. Because, for example, non-invasive mechanical ventilation, we're using, let's say, facial mask. Those facial masks has low compliance and adherence with our patients because it irritates their skin. It's really, the synchrony is low. But with the high flow nasal cannula, we find that our patient is really compliant and they may sleep and sit while there is a nasal cannula with very high flow in their nose. So this is another mechanism of action. There is also flow effects, meaning that the high flow nasal cannula could improve lung mechanics through reducing respiratory resistance. High flow nasal cannula gives you or simulating CPAP effect, though it's not a CPAP. However, it may simulate CPAP effect to reduce resistive work of breathing. Also, the high flow nasal cannula may wash out dead space, anatomical dead space. The anatomical dead space, then if it's like replaced with the pure oxygen instead of the exhaled CO2, it will improve also the gas exchange. And this is how we may see that the washout of the anatomical upper airway of the CO2 would be replaced with oxygen. Using high flow in neonatal and pediatrics, as I said, our colleagues in pediatrics are very pioneer in using high flow nasal cannula in the NICU. So here, looking at the historical and temporal pattern of using high flow nasal cannula from 1997 until 2011, we may see when the high flow nasal cannula was first introduced in 2002, we now see in the pattern and the trend of using, like, let's say, CPAP and nasal, traditional nasal cannula, ventilators is dropping, while high flow nasal cannula is climbing, meaning that the day of using high flow nasal cannula is replacing other modalities such as CPAP and ventilators, meaning that there is a good outcome with the neonates or within the NICU with the neonate patients. Here is another temporal relationship until 2015. We may see that until 2015, the use of high flow nasal cannula and CPAP technically exceeded the VIN days, meaning that the high flow nasal cannula in the NICU may provide a good therapeutic effect in comparison to ventilators. And we know that the more that we are far away from the vent, the less length of stay in the ICU, the better outcome, the less mortality and morbidity, the healthcare costs, etc. So there's a long journey with using vents, especially with young patients. So here, just in conclusion, that use of high flow nasal cannula in the NICU has really a therapeutic and good effect. Looking at the high flow nasal cannula among adults, pre-COVID-19 era, let's say before 2020, high flow nasal cannula was technically used in the general floor, in the ER, and in the ICU. The main indication to use high flow nasal cannula among adults is acute hypoxemic respiratory failure, meaning that those who need oxygen supplement, high flow nasal cannula may therefore supply those patients with their needs. Here, between 2016 and 2018, there has been a lot of randomized controlled trials that compare the use of high-flow nasal cannula in comparison to traditional oxygen therapy and to the non-invasive ventilation. So it has been found and concluded in 4 meta-analysis that the use of high-flow nasal cannula has a superiority effect or a superiority outcome over conventional oxygen therapy, meaning that the outcome of high-flow nasal cannula is superior on conventional oxygen therapy. And it has been found that the use of high-flow nasal cannula is non-inferior to non-invasive ventilation, meaning that the outcome of high-flow nasal cannula is equivalent to non-invasive ventilation to improve the oxygenation and to avoid intubation in patients who have respiratory failure because of hypoxemia, as known as respiratory failure type 1. Take-home message here, in comparison to oxygen therapy, high-flow nasal cannula reduces the risk of intubation. With the second indication is after extubation. So we know that sometimes we extubate our patient to non-invasive ventilation because they are at high risk to have failed extubation and to get re-intubated. So here in this study, 7 randomized controlled trials and 3 crossover randomized controlled trials concluded that high-flow nasal cannula may reduce the risk of respiratory failure after extubation. So high-flow nasal cannula, if used after extubation, may reduce the risk of failure to extubate. However, those studies did not conclude that high-flow nasal cannula may prevent from re-intubation. So still, high-flow nasal cannula has its limitation with respect to re-intubation. The clinical practice guideline before COVID-19 that it's a green light to use high-flow nasal cannula as an oxygen supplement with those who have hypoxemic respiratory failure following extubation, and those with obese patients. It is still conditional recommendation, meaning that it depends on the clinical judgment. It depends on the outcomes of the patient and their underlying medical condition. With respect to peri-operative intubation or like peri-intubation period, that the period before we intubate has no recommendation. The studies did not conclude that high-flow nasal cannula prevent desaturation before intubation. With respect to post-COVID-19 era, let's say from 2020 until today, the high-flow nasal cannula actually provided really a life-saving modality with those patients during the COVID-19. Here, for example, in the United States, and we know United States has been hit really hard and really bad with the shortage of mechanical ventilators. Here, the model, it's a simulating model based on the United States data, showing that in the let's say, looking at the black line, the black line shows the cumulative death in the United States with respect to those who have, or if the model did not introduce high-flow nasal cannula. So if you are in a healthcare facility and if you have no high-flow nasal cannula, the estimated death in the United States was such high, let's say from 5 days or to 60, from 360 death to down to like 260. So the rate was high with those who have no high-flow nasal cannula in their facility. However, when we combined high-flow nasal cannula with mechanical ventilation, we can see that the cumulative death has been decreased. Looking, for example, in New York City, we know that it was all over the news that New York City was one of the disastrous states that had high impact of COVID-19, and they had a significant shortage of mechanical ventilators. The same thing applied here with estimated capacity of ventilators. The black line in the facilities that has no high-flow nasal cannula, we can see that cumulative death was high in comparison to the yellow line when the mechanical ventilator is combined with high-flow nasal cannula in their healthcare facility. So we can say that high-flow nasal cannula, in fact, did save lives with respect to the COVID-19 era. Dr. Hazzani, and including also with our colleague here, Prof. Arabi, published a guideline named Surviving Sepsis Campaign. So in their guideline, how to treat or how to approach a COVID-19 if the patient has hypoxemia. one of their recommendations that high flow nasal cannula is a supplement. It's a recommended supplement of oxygen if the patient tolerated high flow nasal cannula. If the patient did not tolerate high flow nasal cannula, you may try non-invasive ventilation. So meaning here that the use of high flow nasal cannula is recommended with those who have hypoxemia and need supplemental of oxygen if they tolerated the high flow nasal cannula here. There are some concerns, then I'm going to finish up with the high flow nasal cannula. One of the concerns of using high flow nasal cannula that the aerosolization, like the aerosol particles that is produced from the patient. So if the patient is infected, for example, with SARS-2, and the COVID-19 disease, and if the patient is coughing or sneezing or during suctioning, productive cough, the patient there's aerosol particles is coming out of the mouth or the upper airway of the patient. So will those particles may affect the healthcare provider, meaning that will the healthcare provider be affected of the virus if the patient has SARS-2 or other infectious viruses? So there has been an experimental study that concluded that high flow nasal cannula does not significantly affect or transmit the viruses or the aerosol viral particles to the healthcare providers. So what they found that in the laser study, that if the high flow nasal cannula is well sealed, meaning that there is no leak around the nasal pharyngeal airway, so the patient may not affect the healthcare provider. Also, another study concluded that if we use simple face mask over the high flow nasal cannula, we may also prevent from the dispersion of the particles. Here, if you look at the three pictures in the top, patient has high flow nasal cannula and has no simple face mask over the facial area. Here down there, when they applied facial mask over high flow nasal cannula, we can see that the dispersion of the aerosol particles almost has been diminished, meaning that we may protect our workers from the viral particles by applying simple face mask over high flow nasal cannula. Another concern with the patient who's using high flow nasal cannula is the delayed intubation and mechanical ventilation. We know as a clinician that the early you intubate, the early you extubate. So sometimes delaying intubation while you are trying high flow nasal cannula may, in fact, that produce complication and increase maybe more morbidity, length of stay, mortality, etc. However, the studies concluded that high flow nasal cannula may give you a venue to have a successful, let's say, use, meaning that may prevent intubation here if used with the recommended cases and recommended clinical judgment. The second thing is the patient's self-inflicted lung injury. We know that we have ventilator-induced lung injury. The other lung injury could be because of the patient work for breathing. If the patient is working really hard and there is a fluctuating transpulmonary pressure because of the high flow nasal cannula, the high flow coming from the nasal cannula, the patient may get self-inflicted lung injury. So again, we should be cautious on the length of use high flow nasal cannula if the patient is sick and the underlying medical condition is not recovering. The third condition, and maybe my colleague Dr. Shahrani will talk more about it, it's a prone positioning. The evidence practice guideline or the recent studies concluded, one of them concluded, actually the only one that I read, concluded that use of high flow nasal cannula with prone positioning improve the outcome with those patients. So it's not a contraindicated to use high flow nasal cannula with awake prone positioning. And this is what concluded my presentation. I tried to stay within 20 minutes window. And that's it, Professor Had.
Jazakallah khair, Dr. Abdullah. It was very informative, mashallah, concise and to the point. Mashallah, finish on time. I'm trying to gather the question, but if you allow me, I will start by asking these two questions. We understand that the literature in pediatric and neonate are very well expertise in using the high flow nasal cannula. Do you notice before the era of COVID and now out of the COVID, that the utilization, the familiarity, the use of it among all the healthcare providers, in particular your groups, and becoming more familiar and easy to get handled, because in the beginning of the COVID crisis, not every hospital they're able to have it, and there was even a shortage of supply. So did you notice any, for example, get used to it and more familiarity with the staff at your hospital and other hospital, and become more familiar and more friendly, used by our colleagues are using it?
Actually, let me tell you a short story, very quick short story. Because of the shortage of the vents, mechanical ventilators, a lot of like volunteer projects, they try to assemble like automated manual ventilation. So one of the our colleagues with the biomed, they recommended that instead of you assemble ineffective or non-efficient manual ventilator, try to assemble high-flow nasal cannula. So the assembly of high-flow nasal cannula in low-income countries or like in developing countries has increased, meaning that the use of high-flow nasal cannula reached to a global level. So I would conclude from that and assume that the use and the awareness about the advantage of using high-flow nasal cannula increased in Africa and in India and other developing countries as well. So this may conclude with that.
Okay. Any other question? Otherwise, if you allow me to ask you a second question. Dr. Abdullah, I understand, mashallah, you are very much familiar with it. In the cross study, do they find any change on the 30 days mortality comparison head-to-head with CPAP and high-flow nasal cannula, and the outcome in those mild to moderate COVID patients with DSAT of less than 90 who are really requiring a hospital, not in the ICU, but in intermediate area where they were not intubated? Any different in the 30 days outcome, length of stay, and also shifting to mechanical ventilation comparing to those with non-invasive ventilation versus high-flow nasal cannula?
So they concluded that use of high-flow nasal cannula is superior to conventional oxygen therapy, and this is something that more logical and something we already know. But with the non-invasive mechanical ventilation, it was non-inferior, meaning that the outcomes, technically, I'm not sure if their outcome was 30 days outcome.
Mortality in outcome. 30
days.
Outcome.
So I think their outcomes was failure to intubate or not, or like, is it successful preventing from intubation? So the outcome was non-inferior, that both of them were in somehow successful. However, they concluded also that there is a limitation based on the underlying medical condition. So the conclusion with their randomized controlled trial that the use of high-flow nasal cannula versus non-invasive mechanical ventilation has its limitation. It depends on the underlying medical condition, though there is a promising outcomes or promising health effect of using both modalities.
I think they're preparing the question, so I may ask you another question if you don't mind, since we have this 10 minutes for question and answer. Did you come across back-to-back non-invasive ventilation and high-flow nasal cannula in your patient, and they found out that the tolerance of each might be different, i.e., when you try it, because I noticed that sometimes you can alternate high-flow nasal cannula with CPAP, especially keeping in mind that the tightness of the CPAP mask and the discomfort of the patient may not be that as welcome as in high-flow nasal cannula, keeping in mind that the patient comfort and also the positioning from the point of proning. So did you notice any difference on the patient compliance when you change them back to back or change from non-invasive or CPAP to high-flow nasal cannula during your practice of the COVID crisis?
Actually,
precaution, of course.
Professor, that in clinical scenarios, sometimes we treat high-flow nasal cannula as it's a weaning or titration process of non-invasive. It's in fact they are like parallel, each or like they are head-to-head, meaning that use of high-flow nasal cannula is parallel to non-invasive mechanical ventilation to a certain point. If the problem is oxygenation, if there's increased work for breathing and patient is breathing hard and there is a ventilation issue, we may go to BiPAP at that level. But if the problem is respiratory failure because of hypoxemia, high-flow nasal cannula is parallel to non-invasive mechanical ventilation. The compliance rate with high-flow nasal cannula is much higher than the CPAP, or let's say facial mask, because of a lot of factors. Patient may speak, patient may move and sleep more conveniently. The use or the tolerance of using nasal bronze on the nose is much tolerable than full facial mask with high constant pressure. So I would assume that the tolerance with the compliance of high flow nasal cannula is more compliant than continuous CPAP. But again, if the problem is acute respiratory failure because of hypoxemia, high flow nasal cannula can be competing head to head with the CPAP.
Any of the participant is willing to ask, please, we can put it in the question and answer box. Meanwhile, so Dr. Abdullah, I'm going to bother you with another more question, please. Sorry for this. How long you can go with high flow nasal cannula? I mean, you have a limit time, for example, a week, 3 days, 4 days, 2 months. I mean, whatever the duration, maximum in your practice, or come across the literature, they keep the patient in order just to, you know, keeping in mind the crisis of using mechanical ventilation, ICU bed availability, and so on and so forth. So any, during your literature review or in practice, for how long been recorded that the patient was in high flow nasal cannula, for example? Keeping in mind there be some effect on the nasalar, also some effect sometimes on the irritation of the nose, especially when you have a cold flow coming with change of the nasal blockage in patient who have underlying some sinuses like problem.
Yes, actually, Prof. So in a practice, we have a common refrain that it depends. Sometimes it's really bothering me why most of the answer is it depends. So actually, in the clinical practice, it depends on the clinical scenarios. So sometimes the underlying medical conditions, the patient may tolerate longer use of high flow nasal cannula. In other conditions, the patient cannot tolerate because you have to intubate early to prevent any complication associated with the underlying medical condition. However, in the literature, most of the comparison is 48 hours. So they compare it less than 48 hours, more than 48 hours. So the cutoff point is 48 hours.
And more than 48 hours limited, for example?
So most of their measurement, the outcome measurement, rely if it's successful or not, it's 48 hours.
I have a question from
scientifically.
Okay, but I mean they did not say the limit after 48 hours, for example, 3 days.
No, there was no limit. Again, it's depends on the underlying medical condition.
There is a question from Mansoor saying, Jazakallah khair, thank you for an excellent presentation. How frequent we have to change the circuit to prevent infection? Excellent question.
Actually, to be honest, I don't know.
Jazakallah khair.
Yeah, to be honest, yeah.
Another question is, what about nasal CPAP? Do you think it's also an option?
Actually, it is. However, nasal CPAP more of like used on the, let's say, non-intensive care setting. However, in the high flow nasal cannula, it's more like ICU setting. Nasal CPAP used more of the with obstructive sleep apnea rather than high flow cannula used more frequently to prevent or to supply the demand of low oxygen. So think about nasal CPAP. It's more of like home care modality to prevent OSA, obstructive sleep apnea, rather than the high flow nasal cannula used to treat or to recover patients from hypoxemia.
There is a question from Rowan saying,
yes.
Is ROX index effective in predicting the failure of high flow nasal?
Actually, it's a primary indicator to measure, to predict the failure of high flow and success of high flow, successful use of high flow. Yes, it's a primary indicator.
Actually, it's very interesting because I came across the same question. We know that the nasal CPAP is quite often used on pediatric and neonate. And now there is a question here, the effects on adult and neonate are equal in high flow nasal cannula, for example.
I would assume that the compliance and the use of high flow nasal cannula among young patients, let's say neonates, are more successful than adults, based on their keep in mind that the setting we apply with the high flow nasal cannula in neonates is different, completely different than the setting we apply with adults. So we have different let's say characteristics with the setting.
I think again, which is something very important, because you see, sepsis guides campaign have been changed twice during the beginning of the crisis and also at the end. So there is a question here: there is any policy from Habib? I think she's asking: there is any policy or guidelines for using the high flow nasal cannula on COVID patients? Did you come across any guidelines published either by the American Respiratory Care Society or the European Society? Did you come
so the last guideline I'm familiar with, the Critical Care Medicine Society, I think United States, from United States, the Critical Care Society. Also, if it's like more of literature publication, the sepsis campaign was the latest I'm aware of.
The last question before we conclude is the high flow nasal cannula of 60 liters per minute is equivalent to 6 feet. There is any proportional equation to this?
Let's say liter per minute does not equate centimeter of water mercury. So here is pressure, here's a flow. So high flow nasal cannula produce simulating CPAP effect or pressure effect, but technically they do not equate each other. So here we have a flow, it's a liter per minute. Here we have centimeter of work, it's a pressure. So mechanism and physics are different. Do they equate each other? I don't think so. We can't be precise to that point.
I think you're subject to stimulating a lot of question. If you allow me to ask you the last question, if we did not bombard you much.
Yeah, sure.
What is the maximum and the minimum flow can we give to adult patients? This is one of the speakers.
I'm feeling that we may get up to 60 liters per minute. To try to
as a maximum?
As a maximum, it depends on the manufacturer. But however, in the clinical practice, we may get until 60 liters per minute, based on the and also the FiO2, given FiO2 that we want. The minimum, I think, it depends also on the manufacturer. We may get until 20, 15, and then neonate, and here is adult neonate, we may have until 1 liter. So there is high variety, or like there is a wide variety of setting that we may apply here, from very low to until high, based on the, again, work for breathing and inspiratory demand of the patient. Given also here the FiO2, that you may also set the FiO2. It's another point.
When you review the literature, Dr. Abdullah, was any comparison head-to-head between the nasal CPAP versus high flow nasal cannula during the COVID or even in non-COVID case? And which one I think might have superior, based on, of course, the underlying condition of the case, but overall? Because I know now for the last 1 year, we become more familiar with the word high flow nasal cannula as in adult literature, comparing to pediatric neonate, but now becoming the universal language and everybody understanding become more. So did you come across any head-to-head comparison between nasal CPAP versus high flow nasal cannula? And which one?
In the neonates, yes, there is a lot before. And adults, the adult was CPAP, facial CPAP, more like facial CPAP rather than nasal. Again, in the critical care setting, we rely more on the facial CPAP because we want to prevent leak and want to maintain constant pressure in the upper airway and lower airway. So in the nasal CPAP, it's more of like non-intensive care setting rather than facial mask. It's more of like critical care setting. Yeah.
Jazakallah khair, Dr. Abdullah. It was very stimulating and very, very rewarding opening. Thank you very much and hope to see you more often in our meeting. Jazakallah.
Thank you. Jazakumullah khair.
It's my pleasure now and honor to present the second speaker. Second speaker is Dr. Saleh Al-Aisi. Dr. Saleh Al-Aisi is an associated consultant at the University of King Saud University in Riyadh. He is also the deputy of the Sleep Disorder Center at King Saud University Medical City at King Saud University. He's a deputy of the program director of the fellowship program at King Saud for the sleep. He's, mashallah, a reviewer of a journal of Nature and Science of Medicine, and also he's a sleep and vigilance reviewer journal. He's one of the sleep fellowship program developed, and he's a pioneer actually from those people who really established the fellowship in the sleep and sleep medicine. And he was so kind enough in short notice to stand up and give us his talk, and we very much appreciate his quick response and the presentation to us. He's going to tell us about something which we suffer as a physician of using the sleep lab during the COVID and what are the conditions might be used. So he's going to talk about the reopening of the Sleep Disorder Center during the ongoing COVID-19 pandemic. Dr. Saleh, we're very honored to have you and welcome.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Everybody, كيف الحال? Dr. Saleh Al-Aisi, really Prof. Bahammam apologizing for he couldn't present today because of sickness that he have, but he's really apologizing, and I will try to cover what he did really. So I will talk about the sleep disorder and COVID pandemic. Really, when you look at the sleep and immunity, when you have worse sleep, you have higher risk of infection. And this is well known. And also the pandemic causes a lot of elective procedure to be stopped. So that how can you help your patient during this pandemic? So, so our outline will talk about introduction and then objective and general consideration and how we can screen patient and how can we implement our infection control. And then we will talk about epidemiological leads and approach to reopening of the sleep disorder center and how can we continue the surface of the sleep surface of sleep center during this pandemic. Especially we are now running through the second wave. And then we'll talk about BAP titration in sleep disorder center and summary and conclusion. So we will talk about the introduction. The COVID started in, as you know, in Wuhan in last December. And that lead to a complete stopping of our sleep center, especially when it reached the Saudi Arabia during the March. So from March till July, we couldn't do any sleep study because of this really notorious infection that spread to all countries, and some patients really suffer a lot, and there is a number of mortality from this infection. So health system were pushed to the wall, and all elective was diverted to the acute care. So what we can do for our patients, because we what we call it we are doing also, we want to help our sleep patients, so we have to invent a way to help them. So because if we leave them, they will suffer a lot, and they will come to the hospital as a acute exacerbation, and all we are at the maximum limit from the COVID infection. So we should work on telephonic consultation and follow-up, and dispersing medication and prescription through the carrier service and all online portal and respectively. So through these portals, near normal aspect, near normal outpatient service were managed. However, but what about sleep study? All are suspended, and we cannot do a lab service. So the treatment of sleep disorder has impacted even in COVID-19 outcome, and we know that if the patient use CPAP regularly and they sleep well, their immunity will go up, and they could not encounter this notorious infection. However, there is a patient that they are at risk of dying from sleep disordered breathing and severe hypoventilation, and they cannot really wait until the pandemic over, because now we are almost now 1 year, and we're going into the second year. So the pandemic is taking a protracted, unpredictable course. Some people say we are in the first wave. Some people we say the second wave. Some people say we are third wave. And so we struggle with this pandemic. So we have to decide about our patient and how we can do for them sleep study, so that we should ensure and support effort for gradual and safe resumption of sleep medicine service to the pre-pandemic level. Also, we need to implementation of the best practice guideline and protocol for infection prevention and control. And we should minimize exposure of patient and healthcare workers to the virus, and we do not increase the burden of our already used health resource. So that will lead to us to ensure judicious and use of the healthcare resource. Maintain a patient access to care. This is really will improve their outcome and decrease their coming to the ER as emergency situations. So this is will help us now avoiding the unnecessary consultation and attendance. So we need to prompt public health safety, addresses any public concern about it. So we'll talk about this, the general consideration and the background preparations. How can we continue our sleep service? So we have to prepare our sleep disorder center for resumption of the service. And also we have to look into the epidemiological status of the city and province, how they are highly prevalent of infection or low prevalent of infections. So the central preparedness is the healthcare resource, staff education, training to provide optimal service without compromising infection control guidelines. So we need to screen patient, and staff, and screening with point of contact testing. So screening and defining a patient. Patients are identified as symptom of coronavirus, as you know that you should really check on every visit, every patient about the symptom of corona, fever and shortness of breath and cough. And the state, so you have to determine the status of the patient. Is he has infection or not? And then if he presumed negative, or self quarantine and presumed positive. So the patient screening protocol. So pre-screening prior to the appointment, we have to call the patient. Patient portal and virtual meeting, asking him about corona infection risk to be delivered online and retrieved online. So screening at the time of the appointment. This is very important to ask him again about check the temperature, as we are now doing it on daily basis. Even we implement to a Kalna program for symptom and testing status upon their arrival at the facility. So the screening of the staff, very important, not only the patient, but also the staff, and the office staff must be routinely screened for COVID-19 symptom. And they have to really give a questionnaire on every day, and should be encouraged to volunteer any information about their symptom, about they have fever, they feel unwell, even twice per day, because this is really, we don't want our outbreak in our center, because if you have outbreak, then you're increasing already used service. So any staff with the symptoms should not come to the hospital, and he should inform his doctor that I have symptom, encouraging the staff to not to come when they feel unwell. Staff to leave room for sickness or quarantine deficit. Implementation of sick leave policy that are flexible and consistent with the public health policies and demand. So this will allow avoiding really the outbreak in your center. So screening with the point of contact testing, whenever adequate COVID diagnostic test is available, as we are now. So patients should be tested in a reasonable time frame, as we usually screen patient for COVID-19 before sleep study. All of the patients, we screen them. And we do a vigilance testing is another plausible step whenever requested and whenever feasible. So healthcare personnel and the cleaning staff and other hospital staff should be regularly screened with diagnostic tests when COVID-19 is available and logistically possible. So we'll talk about the infection control, ensure that designated staff member, usually clinical coordinator, is responsible for monitoring any COVID-19 update, local health department, hospital managerial bodies, and in-person visit should be minimized by utilizing telemedicine, telehealth, online portals for pre-procedure counseling, education, to obtain an informed consent. So within the center, the physical distance is really important, and we should keep it at least 1 to 2 meters, and minimizing the waiting time in the waiting area and keeping low patient volume as maximum as we can. All this instruction should be passed to the patient beforehand through the telemedicine portals. So patient attendant and visitors are to be minimized, best to be avoided. Usually we are doing the sleep study for adults. We usually will not allow any caregiver to come for translation service if needed. Consider using remote access service. So place alert poster and about the COVID-19 sign and symptom, hand hygiene, respiratory hygiene. And this is really important, this science, and help to educate the public and your staff about this. Really ensure hand hygiene are adequately and accessible, and staff should follow infection disease protocol and procedure for cleaning all patient-related equipment, and also for cleaning reusable equipment, and should be left for at least 72 hours, so that we are ensuring that there is no infection for contact surface like droplet, and infection control guidelines are to be followed. So personal protective equipment, actively monitor and secure personal supplies. In addition to practice judicious use, we should practice donning and doffing, as you all memorizing this and doing it on daily practice. Clinicians and staff, patients should use a surgical mask in the center, and this is now where the surgical mask is recommended in every place. You should use your surgical mask. And you know that we're using the BAB titration device, which is aerosol generating procedures. And this is really should be utilized with appropriate personal protective equipment. All our staff, they should do fitting tests for mask, and if they are not fit, they can use respirator, because this is really dangerous and generating a lot of aerosols. And they encourage to use the goggles and the face shield, all to protect your staff, because they are crucial for your center and also your patient. You have to look into epidemiological status. You have to know what is your country, what is the level of infection. It is high or no, it is small. so that your precaution and your action will go according. So recommendation for sleep disorder center, all sleep study for patients who have COVID positive or COVID suspected, high endemic area with high community transmission, you should really suspend and reschedule your sleep studies. For high endemicity area, sleep study are to be suspended except in case of emergency. Really critically ill patient with hypoventilation. The diagnosis and therapeutic study should be commenced only after careful screening and thorough consideration of the potential benefit and risk. So we talk about the stepwise approach to reopening of the sleep disorder center and to continue your service during the second wave of the infection. So postpone and reschedule all sleep study for patients who are COVID positive or COVID-19 suspect, and postpone all BCG diagnostic and therapeutic in patients who are at higher risk of getting severe COVID-19 illness, like older adult, pregnant women, and patients underlying cardiac, renal, metabolic, and patients who are immunocompromised. There should be no penalties for patient cancellations and missed appointment related to respiratory illness, and reschedule should be readily available to encourage patient to declare symptom. All patients should have symptom screening through the phone before arrival, open arrival in the sleep center. Whenever the testing for COVID infection is available, our patient can be tested in a reasonable time frame. All in-person routine appointment should be postponed and rescheduled. The ASSM and many other society endorse the sleep clinic should consider deferring all elective in-person sleep clinic appointment during high endemicity and high rate of infection. Telemedicine is really encouraging to avoid loss of the follow-up because the patient is using devices, and the adherence to devices more worse than medication. For emergency or unavoidable in-person visit, infection control protocol and guideline are to be followed, and recommended the person protective equipment to be used. So the step, those who in the past 2 weeks had travel or residency history of high epidemic area, contact history with COVID infected patient, contact history with the febrile patient or suspected respiratory symptom from high epidemic or cluster outbreak, reported fever or respiratory tract symptoms. Are the sleep study to be suspended for this subject. CPAP and NIV results, we'll talk a little bit about them. Due to high risk of aerosolization, and titration study and split night study should be postponed except in highly emergent conditions. In setting of suspected confirmed case of infection, protocol of isolation, negative pressure room, preferably with BBE for attending staff are required. BBE for attending staff during the titration is always mandatory. For any patient, even negative patient, you should follow the BBE. Due to high risk of aerosolization, BAP device should not be operated in the clinic room. Even if you want to look for adherence, do not open the devices without knowing the status of the patient. And we publish a paper that talking about the management of aerosol during non-invasive ventilation that you can read about. Site of leak, if you look at the leak, really important to understand from where leak can come. It can come from the mouth leak if nose mask is used. Leak around the mask face, we call it unintentional leak, as you see it in figure A. and leak through the intentional leak port. This is, as you see it in figure B, and the valve. Intervention to reduce leak include the use of full face mask, discarding the nasal mask because you cannot control for mouth leak with an optimal fit. So an experimental model to assess air and practical dispersions, and you have the COVID is droplet infection, and when you use titration device with positive pressure, you can increase the aerosolization and risk of infection. So you can modify the apparatus of the ventilation so that you can minimize the risk of infection by using non-vented mask with what we call it intentional leak through the valve. So at the end, as we speak, so that you have to determine your risk of the shall you start the study or not, depend on the endemicity. If it is high or not high, if it is high, just emergent situation. If it is low, then you can screen patient on regular basis, and then you can do polysomnography without titration study. But and if the patient positive, you have to reschedule them. In emergency, if the patient is at infection, then it is an emergency, and you have to do like portable sleep study or negative pressure room like this, but don't treat them inside the lab. Take-home message, follow the epidemiological day-to-day situation report, and follow the infection control guidelines. High endemic area with high community transmission, all sleep study for the patient who are COVID-19 positive or COVID should be suspended and rescheduled. And thank you.
Thank you, Dr. Saleh. It was very informative, and mashallah, you finished in time like the previous speaker. Please, mashallah, we have almost 422 participants, and for any kind participant, kindly please go to the Q&A box and you carry out your question. Dr. Saleh, so far I have two questions for you from the audience. The first question says, does OSA increase the risk for COVID?
Generally, the patient who have sleep disordered breathing, they are at risk of infection because of their disordered breathing. But however, the OSA per se as a disease that will increase your chance, no, it is usually not increasing your chance of infection. But as your sleep is disturbed, your immunity may be weaned, and then you may be at risk of infection. But OSA itself will not increase your risk of COVID infection.
There is another question is asking, at the Kingdom of Saudi Arabia, are we doing home sleep study? I know that we're doing here in Eastern Province. I'm sure in Riyadh they are doing also too.
Yeah, most of the surface hospital usually they depend on portable sleep study, and we have a lot of center they are doing the portable sleep study, and they're using it effectively. And private sector also they doing it effectively.
Another question is that in your protocol, how soon do you want the test to be done prior to the test? Is it how long? 48 hours, 3 days?
Yeah,
2 days?
usually 48 hours. We should, if we got the result within 48 hours, then we can do the study and titration and investigation that usually BFT and EBG in the same day.
Well, actually,
so we have 48 hours post the result that we can do the study and finish our job.
Thank you very much, Dr. Saleh. Thank you for an eminent presentation, a nice study. There's a question here. Have you ever considered self-sleep test at home?
Yes, it's really we advocate for using portable sleep study when it is available and feasible, because we don't want to bring patient to the hospital just for sleep study, especially if they are meeting the criteria for portable sleep study, because portable sleep study has really narrow angle of what we call it of diagnostic patient, so that if you can use it, it is really important, but you have to make sure that the patient, before he do the sleep study, that he test for corona, because you don't want to contaminate your devices with corona.
Dr. Saleh, do you mind if I ask you two questions from the audience out the scope of the topics? Is it okay with you?
Yes.
Yeah, the first scope is asking, in home setting, would you prefer the BiPAP or CPAP?
Usually for titration purpose, usually we titrate only with the CPAP. I don't like to titrate with BiPAP in home, because really it's very difficult to determine if the patient titrated well in the home on the BiPAP. So just for simple OSA, you can use CPAP. But if it is complicated case, I don't encourage you, because you may treat the patient with wrong device and lead to morbidity and mortality of the patient.
Another question quickly, because of the timing. They ask you, have you ever conducted any home CPAP or BiPAP sleep study in a patient who is bedridden?
Usually in our center we do only lab, and we are because we believe that we have a lot of hospital around us doing the same job, but they do the portable sleep study. And for patient, even if he is bedridden, this will not deprive him of the treatment, especially if he because some patients they have a bad cognitive because of the sleep disordered breathing, and once you treat their disordered breathing, their cognition become more what you call it fine, and they return to their baseline. But the bedridden will not deprive the patient of the treatment.
There is an excellent question from, as all the questions been asked, from Mr. Al Faisal. He's asking, very interesting. We know, Dr. Saleh, that what they call it post-COVID syndrome, not post-COVID pneumonia. And one of the post-COVID cognitive and neuro effect is the sleeping deprivation, which is something is really noticeable in a lot of publication in news. And those patients who happen that they have obstructive sleep apnea, and also they already had COVID before and they have a sleeping deprivation, how would you adjust your sleep, your BiPAP setting or non-invasive setting in those patients? Very challenging, by the way.
That's mean really the question was lengthy. I did not grasp it.
We know that one of the complications of post-COVID syndrome as a neuropsychiatric is a sleep deprivation, which is
deprivation.
Deprivation, sleep deprivation. Sorry. And in those patients who already have a obstructive sleep apnea syndrome, who really had COVID, how would you adjust your CPAP or BiPAP setting on those population?
I think he means that the patient who have COVID and they have like
the post-COVID complication.
Post-COVID complication.
Yes.
I believe that usually if you want to do a sleep study or titration study, even for patient post-COVID, you have to make sure that the patient is cleared from the infection. Because if you want to titrate the patient, for example, use ventilation device, even at home, his household will be at higher risk of infection, because will be no control over aerosolization. So you have to make sure, number one, that the patient is really cleared from the infection, and then you can diagnose him and treat him, because if you treat his sleep disorder and improve his sleep deprivation, this will really reflect on his what we call it prognosis.
We have 2 minutes left, and there is a very interesting question from Mr. Abdul Majid. Do you think that by BAB further spread the COVID to all the lungs? Mind you, we are just having a rescue management for a BiBAB or CBAB and those patients who came to us with COVID. And do you think that using those might really spread the virus further down to the lung?
Yes, aerosol generating procedure, positive pressure devices is really risky devices, and all our staff, when they do titration study in our center, we are not allowing them to enter the room, even the patient is corona negative, without using the effective mask, either fitted mask or respirator if they are not fitted, because even with negative with negative corona test, that doesn't roll out corona, so that you have really, especially when you're using such devices.
Jazakallah khair. The last question, Dr. Saleh, and sorry for taking that much. Do you notice in your center or any literature that the mortality of sleep breathing disorder patient before and after COVID have changed or increased?
I don't know about this question.
Jazakallah khair. Thank you very much, Dr. Saleh. We are very happy to hear you with us, and wish inshallah speed recovery and tahur inshallah Professor Bahammam. We'd like you to extend our thanks and gratitude to you, and also wishing a good recovery for Prof. Bahammam. And we'll see you again in the next.
Please everyone pray for Prof. Bahammam.
نسأل الله سبحانه وتعالى يتم عليه بالصحة والعافية ويجعل الطهور. جزاكم الله خير. Dear participants and audience, we come to the first break for 10 minutes for Salat al-Isha, and then we'll be back inshallah in 8:20 to start the second part of the talk. جزاكم الله خير for listening, and see you in 10 minutes. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد. جزاكم الله خير. And just before I introduce my next speaker, kindly would like to ask the participant, if you have any question, please, there is a box of Q&A question will be asked. And alhamdulillah على إتمام الجزء الأول from the conference, and will be starting in the second part. It's an honor and privilege for me to present my dear colleagues and brother and friend, Dr. Mohammed Al-Shahrani. Dr. Mohammed, he is associate professor of critical care and emergency medicine. He's a director of the ICU, and also he's a vice dean of hospital affairs and director general of King Fahd Hospital University. He's mashallah Saudi board awarded in honor of 2007. He has a lot of publication nationally and internationally. He's very active and dynamic role and setting the gear for the critical care in our hospital. And he's the director of the Saudi Council for his specialty for the critical care. And he's going to talk to us in this coming 20 minutes, awake prone for a patient with COVID-19 respiratory failure. Dr. Mohammed, without you, you're honored to be with us.
Assalamu alaikum. Good evening, everyone. Thank you, Prof. Hatem, for the nice introduction. Really humbled and honored to be introduced by you as one of my teachers and professors at the university. And I'd like to get the chance to thank Dr. Noor and the team of Respiratory Care Department for this invitation. I'm really glad to be here this evening to talk about this topic, which is awake prone for patients with COVID-19 respiratory failures. As everyone knows that the pandemic was so aggressive over the last year, and as medical practitioners and the critical care units, physicians, respiratory therapists, nursing, all others, we faced a lot of challenges during dealing with those patients. And we already know that mechanically ventilated patient, COVID-19 patient, the mortality is already very high, ranging from 30 to 40, and some countries reporting up to 70% mortality for those invasively mechanically ventilated patients, which bring the question that is intubating those patients and putting them in mechanical ventilators as a safe practice, or should we try to avoid getting them intubated? So nothing to disclose, and we'll start by this real case that we had last month. A 57-year-old male presented to our emergency department at King Fahd Hospital of the University, shortness of breath, cough, and fever for the last 3 days. He has healthy otherwise, but a bit obese. His BMI was if I remember, above 35 or 38. And this was his vital signs at that time. Blood pressure was okay, tachypneic, and this is his SpO2, 85% on room air, and temperature of 38.6. And this is his chest X-ray showing down. And for those dealing with those patients, this is a very common scenario. This is a very common presentation. Such an X-ray, such a vital signs in the emergency department. So simply we connected them to oxygen, high flow oxygen via non-rebreather face mask, and trying to bring their autosat to normal levels. Some of them, they respond, and some of them, they look tired, working hard for their breathing. So we need to connect them to something, make their work of breathing less, and to avoid getting them intubated later on. So objectives of this talk is, what do we know about prone positioning and awake proning, and what we don't know. And at the end, we'll talk a bit about ongoing trial that trying to answer those questions. So as we all know, a year back from now, the WHO announced the COVID-19 pandemic. And this is like 3 days or 4 days ago from the WHO dashboard. So 3-4 days ago, we reached 113 million confirmed cases, death 2.5 million deaths, and with a daily new death of around like 11,000. So again, the pandemic is still ongoing, still aggressive, hoping for the best with the vaccination programs now. So during the peak of the pandemic, and this is to be more clear here in the Eastern Province, we had the peak on June, July, and August, something like this. During those months, and other countries, they get it earlier, like New York and Europe, in like April, May. So during that time, healthcare system were overwhelmed in some countries and some hospitals. And here we are talking about the resources and mechanical ventilators. So the idea of having or bringing something to avoid or to reserve those patients from being intubated and invasively ventilated was a must. And awake prone is one of those options that brought up. Even this kind of term was there a few years back, but this is the time where really used more frequent. So does awake prone will help in avoiding intubation and reserve more ventilator for those who are really in need for them? This exactly what the question for every practitioner who's bringing their patients on a prone position while they're awake. So we need to know how prone works in intubated patient, and is it effective in prone clinical outcome in patient with acute lung injury and acute respiratory distress syndrome. So this is what we call indirect evidence. So in intubated patients, we know that there are some evidence about proning. So let's talk about some pathophysiology to understand how prone will work to save those patients from being intubated, and how prone work to improve their oxygenation. So we already know that acute lung injury, acute respiratory distress syndrome increase the respiratory drive, and this will increase the respiratory rate, increase the shunt fractions in the lung. Bindolf phenomena, where the gas moved from more recruited to more de-recruited areas in the lung. increase the VQ mismatch. So because of the respiratory edema, variable lung collapse and atelectasis, hypoxemic vasoconstriction, a lot of microthrombosis, and this was brought a lot in the literature of COVID-19, and this might why we see some patients are really hypoxic while their chest X-ray, there are changes, but it's not the changes that we expect with this level of hypoxia. So maybe from the microthrombosis that they had, so increase the dead spacing and inefficient ventilation. Also, we know that sometimes there increase intra-abdominal pressure and third spacing, and this will cause more pressure on the lungs and decreasing the lung capacity, vacuum capacity, and functional residual capacity. Again, initial lung injury by infection, viruses, bacteria, but here we are talking about viral infection, so capillary leak, lung edema, impaired gas exchanges and mechanics. This will increase the drive, and this will cause patient self-inflicted lung injuries. And again, the cycle become virtuous and continuous. So now how prone works, why prone can improve outcome in those patients. As we said, there is dorsal and dependent region of the lungs are more susceptible to de-recruitment in supine position. This is just by gravity. And pressure also exerted by the lungs and heart. Also, there is some abdominal content that exert another extra pressure to the diaphragm and the thoracic cavity. This will reduce the vital capacities and functional residual capacity. There are a lot of accumulation of fluid and pleural spaces, cause infection, edema, and so on. This also will cause high lung compliance in non-dependent region. When it comes to prone positioning, we find that it will result in more even alveolar ventilation, which we call homogenization of lung aeration. Also, infiltrate redistribution. So this somehow will optimize the VQ mismatching that happened. Also, will reduce the compression that exerted by the lungs and heart, and also by the abdominal content. Also, this will decrease the compliance in non-dependent region, and also might help in facilitating drainage of secretions. This is a simple slide. When it comes to supine positioning, there is alveolar size variation, where in the prone positioning, there is homogeneous alveolar size. This will help in more aeration. The strain that brought in supine positioning on the lung will almost disappear or decrease in the become homogeneous strain in the prone positioning. When we're talking about evidence of prone, what we call indirect evidence, because this happened in intubated severe acute respiratory syndrome, and this is a landmark trial. Intensivists and respiratory must be aware of this, published in 2013. Simply, those group, their indication for that for the proning in that trial group or those cohorts was severe ARDS, and those were defined by having a PF ratio of less than 150, and also FIO more than 60%, people more than 5. Their protocol was started yearly within 1 hour, and at least 16 hours needed per day, according to their protocol at that time, with the minimum tidal volumes. So it was yearly, prolonged, and low tidal volumes. And this is the result that they get at that time. It was an amazing result to see their proning at that time, which with a good powered study. So brought the mortality down from 32.8 down to 16%. Some people doubt those results, and they said, okay, this is too good to be true, but that was the result. And prone was practiced and actually one of the recommended procedures for those with severe acute respiratory syndrome. A recent systematic review and meta-analysis, including almost 9 or 8 trials. When it comes to mortality overall, it's borderline favoring prone positioning. But when they look at subgrouping those trials, for those who spent prone positioning more than 12 hours, there was significant mortality benefit compared to those with less than 12 hours prone position. So here we are saying that if you will prone patients, you need to give them time. Also, when they segregate patient moderate to severe compared to all, There was mortality benefit when you use it for moderate to severe compared to all ARDS patients. So again, it might just enhance the practice that we nearly prone position might really be helpful for those moderate to severe ARDS. And if you use it at least 12 hours or more. So what about awake prone, the title of our lecture this evening? So does awake prone position patient COVID work? Or do we use it? Actually, this is a survey and published data from colleagues that I execute them to share their slides that when they asked the physician in COVID-19 era, do you use it? Almost 43% they're not using it. In selected patient, like 46%, 11% all the time use it. So simply, there are 43% they don't use, and 67% they are using awake prone positioning. So you can think about it when it comes to physician preference and as a practice. Is there any evidence behind using awake prone positioning for COVID-19? So unfortunately, the evidence is scattered and small. This is a very recent rapid review published in last August 2020 that included 29 publications, and it was almost 364 patients. 11 of those patients prospective, but a very small size study. 13 were retrospective studies, and 5 single case reports. Simply those studies, and this was from almost everywhere, Europe, North America, South America, and Asia. All study almost showed or demonstrated improvement in oxygenation and prone positioning. But this effect was not sustained after supine position in most of those studies. Only 2 studies used non-invasive ventilation. They told when you bring those patients back on supine and you connect them to non-invasive ventilation, the improvement in oxygenation might be maintained. 29% was the rate of invasive mechanical ventilation in those cohorts. There was some adverse event, discomfort, nosebleed, sternal pain, back pain, and intolerance. And we'll come to this in details later on. So what we don't know as of this time while we are speaking this evening, does awake prone improve patient important outcomes? So when we talk about important outcome, here we are talking about mortality, for example, avoiding invasive ventilation, ICU stays, such important clinical outcome. This is what we really concerned about. And if yes, what's the optimal duration of awake prone? Should we keep those patients awake prone? How many hours per day? 5, 6, 8, 10, more, less? We don't know. Is there a harm or potential harm for patient or healthcare workers? Not really sure. So the recommendation that this finding cannot be generalized without confirmation in a large trials. So again, does awake prone position prevent intubation or delay the inevitable? Does it improve survival, cause harm due to delayed intubation? If it's effective, what's the optimal duration? Here I will talk about ongoing trials. This is a trial that we are part of here at King Fahd Hospital University and in Saudi Arabia, and proudly that the lead for this trial is at McMaster University, Dr. Walid Hazani and his group. And here in Saudi Arabia, the PI is Prof. Yasin Arabi. He's going to speak after me. And there are maybe, I'm not sure how many centers in Saudi. We made 3 or 4 centers from Saudi Arabia. Other centers you can see from the slide, from Canada, US. They're also from Europe, Poland, and I think now some centers started in other countries. So simply, the objective of this trial to determine if awake prone positioning in COVID-19 patient with hypoxemic respiratory failure reduces the need for invasive mechanical ventilation. The study designed a pragmatic, multi-center, parallel group, stratified, randomized control trial. The target sample size is 350 patients. Eligibility criteria, so any adult patients, suspected or confirmed COVID-19 patient, hypoxemic requiring more than 40% oxygen, chest infiltrating oxygen interrupted by the treating team, interpreted by the treating team, admitted to the ICU or an acute care unit where hemodynamic and respiratory monitoring is feasible. Exclusion, exclude any patient who really in need for intubation, low GCS patient, contraindication to prone positioning, the patient or the family reviews, hemodynamic instability, big BMIs because of the feasibility for those patients or practicality, they cannot, most of them, they cannot do it, skeletal deformities of the neck, or of course, pregnancy, any patient who already for not resuscitation, or there is no resuscitation order, what we call DNR or DNI, or if there is a prone already done for the patient more than 1 day prior to randomization. Randomization is a central online randomization, is stratified by site and severity of hypoxemia, so we can know which subgroup will get more benefit if there is. Intervention, simply the RCT protocol is 8 to 10 hours with 1 to 2 hours break in supine position. This is per day. Prone sessions will continue daily until this is the stopping criteria. A relative improvement if IO2 by 40% from the baseline for 24 hours, the patient is intubated or until discharge from ICU. Okay. So the control, of course, there will be no prone, and the practice, the usual practice will be done by connecting them. So Dr. Abdullah spoke before that how we keep oxygenating those patients. It's okay for high flow nasal cannulas, non-invasive ventilation. Of course, helmet will not be, practical to prone those patients, but I'm talking here about face mask interfaces and high flow nasal cannula mainly. Or an face mask. Sorry?
2 minutes.
Yes, I'm almost there. Study outcomes, we are looking for endotracheal intubation within 30 days of randomization, mortality at 60 days, invasive ventilation, non-invasive ventilation 3 days, ICU hospital 3 days alive, and complication from proning. The study was funded by many agencies, among them KMARC in Riyadh, King Abdullah Research Center. Dr. Yassin is the lead for this in Saudi Arabia. Participating center, as I told earlier, from everywhere. And again, I will not spend much time in explaining the flow, the study flow, but eligibility criteria is clear, consenting, the randomization, and we'll go for intervention or the group. Potential challenges, compliance, and this is, we found that very challenging. Most of patients, elderly, they don't like it and they don't keep themselves prone. We're trying to convince them, and this is even without, not in the study, this is in the practice. Some of them, they don't like it. Some of them, they accept it. So this is a challenge. In IV, this is the way they look when we connect them in non-invasive ventilation, for example. Some physicians, they don't buy it, they don't like it. This is another challenge. So in summary, to my talk, awake prone is frequently used in hypoxemic adult with COVID-19. The effect of awake prone in patient important outcome is unknown, and we're still looking for to know this. Mandating awake prone with proof of efficacy and safety is not appropriate. Healthcare worker, risk of exposure, delay intubation. So we don't know this yet, but we're trying to know. Also, COVID prone, this is what the trial that we're conducting now, is trying to answer those questions. And this is not only, I think there are 2 or 3 other registered trials, if I'm not mistaken, also looking for the same answers. Thanks to all heroes out there, physicians, respiratory therapists, nurses. You need to get this chance to thank them, and I can tell how much sacrifices they pay during this pandemic. So thank you, everyone, and this is my ICU and ER departments, and I'm happy to answer any questions. Thank you.
Jazakallah khair, Dr. Muhammad. It was very informative and timely manner. I have 4 questions so far from the panelists. The first question is that could the awake prone increase incidence of aspiration?
So short answer, we don't know, to be honest, but we used to keep those patients in PO during prone. to minimize the risk of aspiration. This is because we believe, at least theoretically, it can bring a risk. And, you know, with those intubated, ventilated, sedated, the risk is higher. Those patients awake, so unlikely there will be a risk. But for a patient who is really sedated, we usually tend to keep them MPO because of this risk.
And in awake proning, you agree? Another question here is that early proning is better than late proning. Is that correct?
Again, as I told in the slide, we don't know the answer yet. We are trying to answer those questions, but anything will say even the question. I think this is the most hot question now: early intubation versus delayed intubation in COVID-19 patients. At the beginning of the pandemic, people think that we need to intubate them early, bringing them. But with time, we are seeing that mortality is very high in those invasively mechanical ventilated. So some recent report talking about this is not safe practice. We need to give them time trying to avoid intubation. So if you ask me just like an observation, I would say yes, awake prone might be early awake prone will be helpful rather than late. But we're still waiting for a definitive answer from clinical trials.
There is another smart question here. Why there is no way yet to suspect prone complication by criteria before application?
I'm not sure what complication the person who's asking. We know awake prone is the complication, to be honest, is very minimal because you're asking someone who's really awake to prone himself, like if he's sleeping in his abdomen. So we don't expect much, and it's just something voluntary. If he feels pain or something, he can turn himself. He's still communicating with people. So I don't personally think there are a lot. And we are, by the way, the trial already, we are on 2/3 of the recruitment worldwide. I think 270 patients recruited so far. So we're left for 80 or 90. So we don't see that much complication from awake prone, to be honest.
Another question, what is the minimal duration you can use? And what is the maximum duration from your reviewing the literature?
So the minimum duration, so literature is, as I told you, it's scattered everywhere. Some people talk 2, 3, 4 hours, but we believe that minimum of 8 to 10 hours will be enough. If we compare this to prone in invasive ventilation, the best evidence telling that more than 12 hours for those patients was they found the best effect and outcome.
The last question is that does the prone position increase risk of infection?
Again, if you're talking about,
does it increase the risk of infection transmission?
A transmission, okay.
Yes.
So I don't think prone because it has something to do with the way of ventilation. The same infection control measure. I don't believe that awake prone by itself will add something. If you are keeping a patient on CPAP or BiPAP in a room where there is no negative pressures or HEPA filter or something, the risk is there. Whether the patient is supine or prone, I don't believe it will increase by only proning the patient. So it will not affect. We don't know the answer yet, but I don't think so, because at least theoretically speaking, it's the risk of infection transmitted the virus has something to do with the way of ventilation, the infection control measures around the patient, the negative pressure rooms, HEPA filters, staff, PPEs, and so
on. So far in your research, there is a question here. How many patients dropped from the trial? And do you expect any patient accepting the trial?
So you mean they started, they decline. Actually, I can tell you, I don't have numbers now, but there are patients who they're starting and they're not, we call them, they're not compliant with the protocol. If you remember, we said 8 to 10 hours per day. We ask them and we give them breaks, like 1 hour break if they need. It varies. I think our discussion with the steering committee last time, it's from center to centers. I think personal observation, elderly, they are not accepting it easily, like young. But there are patients, to answer the question, yes, there are patients less compliant, and some of them, at least our center, one maybe declined the consent, and he said, I don't want this anymore, something like. But again, those results we'll know all those answers later on when the result published.
Jazakallah khair. All the audience, they appreciate your presentation. And Jazakallah khair. Thank you very much. Hopefully we'll get the result of the study soon and it will be amazing as usual. Thank you very much. Jazakallah khair. It's my pleasure now and honor to present my dearest friend and colleagues, Professor Yasin Arabi. Professor Yasin Arabi, for people who really know critical care, he's a well-known figure worldwide, nationally and internationally. He's the chairman of Department of Critical Care and National Guard in Riyadh, and also he's the chairman of Respiratory Care Services as King Abdul Aziz Medical City, Minister of National Guard in Riyadh. He's a professor in the same college, and he also associate professor in Monash University in Australia. MashaAllah, tabarakallah, has more than 400 publications worldwide in peer-reviewed articles. And he's going to talk to us about something that's very interesting which come up to the market. In primary literature, Hamlet was used in non-invasive ventilation on those patients with respiratory failure. Now we are using it in COVID. So I'd like to hear his experience in this field, and we're very honored to have you, Prof. Yasin.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Hatem, for this kind introduction and for the organizing committee to invite me to this important meeting. It's my pleasure to be with you here and also to have this presentation after Dr. Muhammad excellent talk. I think it comes as a natural part of the algorithm of managing patients with severe COVID. So as you mentioned, helmet has been around for the management of acute hypoxemic respiratory failure for a while as an interface for delivering either CPAP or non-invasive ventilation. And I'm going to show you some of these small studies. There are not been a lot of studies so far, but there are some studies that are encouraging about its use. So helmet has gained popularity because it is effective in delivering positive pressure to patients with acute lung injury and in delivering higher PEEP level than what you could provide through mask non-invasive ventilation. This is a study, multi-center randomized controlled trial in 4 Italian centers, where patients with severe hypoxemic respiratory failure due to pneumonia were randomized to receive helmet non-invasive ventilation or oxygen delivered through Venturi mask. So this is helmet versus oxygen through mask. And what they found that the patients with helmet, only 15% required intubation versus 63% in the control group, which was significant. So it really cut down the intubation by almost 3/4. It reduced it to relative risk of 0.24. Another study, also not really large. This is a study in patients with community-acquired pneumonia in the emergency department, were randomized again to helmet versus standard oxygen therapy. The study is not large. It's 20 patients versus 27 patients. And the primary endpoint is oxygenation. And oxygenation improved dramatically in the helmet group versus the oxygen therapy group. And this makes a lot of sense because you are delivering positive pressure into the lungs. So significant improvement in oxygenation. Another important trial, which was published in JAMA, this trial randomized patients who are started already on mask non-invasive ventilation. So this is a patient who has ARDS, started on mask non-invasive ventilation, and then randomized to continue on mask and IV versus helmet. And what the trial showed, this trial was designed to be a larger trial, but it was stopped early because of benefit, showed that helmet was associated with significant improvement in survival and in a major reduction in risk of intubation. So intubation happened in the helmet group only in 18% versus 61% in patients who were on mask and IV. And this is an important slide for us as we're going to explain how helmet work. You could see in these two groups, again, not very large study, 39 patients versus 44 patients. The patients with the helmet received on average higher PEEP compared to the mask NIV, and lower pressure support, so 8 versus 11, and lower FiO2. So what this information tells us that when you use helmet, you'll be able to provide higher PEEP, and probably don't need to give too much pressure support to ventilate the patient, and you could achieve better oxygenation, so you don't need to give higher FiO2. The authors conducted a long-term follow-up and confirmed that the survival benefit continued up to 1 year after randomization. So very encouraging results for helmet. This is a recent systematic review and meta-analysis published in JAMA, looking at different studies of different types of oxygenation strategies in patients with acute hypoxemic respiratory failure. And what it shows here, that compared to standard oxygen, masked NIV did not make a difference, did not make much difference in terms of mortality. High flow did not make much difference, maybe a little bit, but not huge. But the one based on this systematic review that made reduction in mortality was helmet non-invasive ventilation. When you compare it to other strategies, mask NIV versus high flow, there is no difference. Helmet NIV versus mask NIV, reduction in mortality. Helmet NIV versus high flow, there is reduction in mortality. When we look at the intubation, very similar results. It appears that helmet, compared to other strategies, compared to oxygen, compared to high flow, compared to mask NIV, appears to be associated with better numbers of ventilation, intubation, and lower mortality. This picture illustrates an important thing that we need to be aware of. So the helmet is a chamber placed over the head. It has a neck seal, and it has these tubes. One is inspiratory, one is expiratory. On the expiratory, you put a bacterial filter. And the way to use helmet is, you see in the literature, there are two different ways. One is use it for CPAP, and for CPAP, it's connected to oxygen and air mix with the humidification. So it's simply connected to oxygen flow. You don't connect to ventilator, but has to be high oxygen. And there are detail about this, but it's basically, so that's why it gained a lot of popularity in Italy, because it's used on the wards. And to give the PEEP, you put a PEEP valve on the expiratory limb. So this is CPAP. The pressure support is you connect the helmet to ventilator. So the inspiratory limb and expiratory limb are treated like mechanical ventilation, and you deliver pressure support in some detail that I'm going to talk about in a minute. So this is a different way. This is from our ICU, a patient on helmet connected to the ventilator, inspiratory and expiratory limb. This is a helmet CPAP, patient connected to oxygen from the wall. This is a volunteer connected. And on the expiratory limb, there is a PEEP valve that controls the amount of PEEP. So helmet in COVID-19 gained popularity. You've seen this probably on the news. In Italy, it was used widely because it helped expanding the capacity of ICU. So they used it on the wards. Also, when there were limited number of ventilators, this helped supporting a lot of patients. But also another aspect of helmet is the aerosol generation. This is a study actually from 2015. On the right side, this is a face mask, and you could see the jet of aerosolization that is coming out of the mask. So this is a patient on face mask. You see here the jet coming out. While in helmet, it's almost completely contained within the helmet, very limited leak, unless there is a leak around the neck, like what you see on the left panel. But if there is a good seal, the amount of leak and nebulization is so limited. It's another advantage of using the helmet. So in Saudi Arabia, we started helmet program, if you wish, when the first wave in pandemic in May and June, and we had the pleasure of having the Saudi Council for Health Specialty helping us in setting up training sessions where we got some of the international figures on helmet talking about this topic. And since then, it has been used in many sites, as I'm going to talk about. So this is again from our ICU. And I'm going to just show you, these are X-ray from a patient yesterday. This on the left side is X-ray before the helmet. And this is this morning, 24 hours later with helmet. You could see how much the lung has improved. There's significant recruitment of the lung. This patient is requiring PEEP of 12, 14, and FiO2 100% on this X-ray. You could see the X-ray has improved a lot. Now, was this going to translate to reduction of intubation, reduction of need of intubation and mortality? We don't know. That's what we are trying to answer in our clinical trial that I'm going to talk about. At present, the evidence that supporting helmet in COVID-19 is really limited. There's some studies, cohort study, showing that it reduced intubation by 56%, but this is just observational data and cannot really have a good comparator here. At present, there are multiple randomized control trials being run for helmet. We're pleased to have one of them running. Our trial is comparing helmet versus standard of care. We're aiming to include 320 patients, but there are some other studies ongoing with different comparators. They are not the same, but hopefully we'll get our trial to help answering this important question. So this is one of the studies. This is from Sweden, looking at CPAP versus high flow, and the endpoint is ventilation-free days. Our trial is sponsored by KMARC, King Abdullah International Medical Research Center. We're hoping for 320 patients. Will be multi-center randomized control trial soon. We are randomizing patients to receive helmet versus standard of care. So we're including in this trial adult patients who are admitted to the ICU with suspected or confirmed COVID, who have acute hypoxemic respiratory failure with PF ratio of less than 200 and can have intact airway and can follow instructions. There's a list of exclusion criteria which include, for example, hemodynamically unstable patients, imminent intubation, which is important. So somebody who very, very likely to require intubation right away, don't put him on helmet. This will put him, has no value, and it will put patient at risk. A patient has to be awake, obviously, for helmet. We're using helmet made of a transparent latex-free material, and this is connected to a mechanical ventilator using a double lumen circuit. We're using bacterial and viral filter, and the helmet has to be tied down with the underarm pads. And we usually give the patients earplugs to reduce the noise from the airflow within the helmet. We use unheated dual limb breathing circuit. The RT will do the pre-operational check on the ventilator before putting the patient. And you need to explain it to the patients because some patients become claustrophobic, has to be explained well before you place it. So this helmet can be used with a ventilator or some in non-invasive machine, not all the non-invasive machines. We set our protocol is to place the patient on pressure support, typically pressure support 8 to 10 with PEEP 8 to 10 and FiO2 100%. The most important thing is to give high flow exceeding 50 liters per minute and sometimes higher, more than 100 sometimes. and should be inspiratory rise time short, 50 milliseconds, with end flow cycling of 50% of maximal inspiratory flow. If the patient remain hypoxic, we increase the PEEP by 2 centimeters every 3 minutes to achieve saturation more than 90%. And we try not to exceed maximum press support and PEEP of 30 centimeters of water. The target is to reach FiO2 of less than 60%. Then if the patient stabilizes, we start to wean pressure support. If the patient rest rate is less than 30, titrate PEEP if the saturation is more than 92%. And it can be discontinued if the patient is on pressure support less than 10 and PEEP of equal or less than 5. And the patient can be switched to face mask, but sometimes we switch them to high flow nasal cannula. Some patients become restless with the helmet, so it's not unusual to use dexmedetomidine, and sometimes we started before the helmet to improve compliance. We recommend not to use any other intravenous sedatives such as benzo or narcotics. If the patient becomes agitated to the point that he requires drugs, then he's likely to need to be intubated. So don't keep, it will be too risky to start to give all these sedatives. Important issue is nursing care, perform oral care. Feeding can be given through a straw. There's the opening for feeding of these patients. And there are detailed and several articles talking about helmet bundle in patients with COVID-19, which include noise reduction, as I mentioned, the issue of earplugs, counterweight fixing system, and humidification. So I'll talk about this. So some people used, instead of fixing this under the axilla, which causes stretching, some people use anti-gravity. We find it a little difficult, but I think it's, for some patients, may be useful. Humidification. For humidification, you have to use not heated humidification. It has to be room temperature. Otherwise, it will fog, will give you a lot of fogging inside the helmet. So what we are actually, with the thing that worked with us is use bubble humidifier at room temperature that gives the humidified air in the side port here in the inspiratory limb. This picture is from one of our great colleagues, Mr. Amar Zmei, and our respiratory therapists who've been doing really fantastic job doing this. We have so many patients on helmet now. The control group in the trial, our patients can receive low flow oxygen or high flow nasal cannula or non-invasive ventilation through nasal mask or face mask or total mask. The decision to intubate patient, we leave it in the trial to the treating team, but we recommend the following, that the patient should be assessed frequently. Important thing, if the patient has persistent or worsening respiratory failure, should not wait too long. And I think give some time. It's remarkable with COVID that there are patients who are hypoxic but look great. So sometimes it's okay to give them some time, but it's important, on the other hand, not to push too much until the patient really extremis. We're looking at an endpoint of 28-day mortality as a primary endpoint, and there are several secondary endpoints in the trial. They will continue helmet until the patient either improve or require intubation, or he become intolerant where we remove it. But we are collecting data until day 28, and then we have a follow-up data at 180 days. The sample size calculated as per the slide to be 320 patients. I'm very pleased to have many of my colleagues applying for IRP. I think many hospitals have applied already. In our hospital, we are already recruiting. We have today recruited the patient number 28. So that's in last 3 weeks. So I think the study probably going to be conducted rather quickly. So especially if we get all these hospitals participating, would be really fantastic. So in summary, helmet CPAP and non-invasive is promising modality for acute hypoxic respiratory failure. I have to say it has learning curve, and the respiratory therapists and the team need to be familiar of how using it. Otherwise, not doing it right can be problematic. Existing data suggests that it will lower mortality and intubation. Data on COVID are limited, and hopefully our trial will address this question. And thank you very much. And I really thank the Saudi Critical Care Society and our respiratory therapy colleagues. They've been doing amazing job actually in applying the helmet, teaching the helmet, and helping us understanding the optimal way of using this. All hospitals have been fantastic, and I've heard many great news about using this. Thank you.
Jazakallah khair, Dr. Yassin. Thank you very much. MashaAllah, on time and as eminent as usual. I have a question from the participant. The first question is, as long as there is a minimal leak both for total face mask and helmet, why and how is different to delivering the positive airway pressure?
I think the leak with the helmet is less no matter what we do. The other issue, the helmet allows you to give higher pressure. And this has been shown in many studies. So it gives you, you'll be able to give higher pressure with less discomfort to the patient. The problem when you give very high pressure with the face mask, you need to tie it too much to the nose and it will blow air in the patient's eye. So it can be very uncomfortable. On helmet, you will see patient generally more comfortable, but there are some patients who do not tolerate it, I have to say. There are some patients do not like the helmet, but majority do. And when they tolerate it, they do okay. So it doesn't put pressure on the air, on the nose, doesn't cover their mouth. They can still communicate and see properly. Doesn't blow air in the eyes. The other thing with prolonged use of mask and IV, we've seen patients develop pressure ulcers on the nose. While this one, the risk is much less.
Indeed, we notice it in those patients who really identify respiratory failure, and we have a lot of problem with, especially if unfitted face mask with the nasal and bridging necrosis. Another question, Prof, do you use the helmet during sleep?
Yeah, so patients, our study is for patients with acute hypoxemic respiratory failure. This is not for sleep apnea, if that's the question, but for the patients who are in helmet, they sleep with the helmet. I mean, simply they sleep with the helmet. And many of these patients, because of the dyspnea, they are sleep deprived. So when you put the helmet, you see them fall asleep. Yes, there's no problem, of course.
Dr. Shoghi is asking, thank you for this interesting presentation as usual. From your personal experience, how common is claustrophobia during treatment and what is the best way to deal with it?
There are so maybe 10-20% of patients don't like the idea of having something on their head. So I think it's very important to give them good explanation. I think this is the first thing to do, is give them good explanation what you are doing and how it works. And some patients require to be started on dexmedetomidine before. And we found this to be very helpful.
So the question to the same drugs, why dexamethasone drugs is only used for sedative patients rather than others?
Because it doesn't affect respiratory drive.
So this is another question also. Why did you make helmet more effective than other modalities? Why do you think its helmet is more effective than other modalities?
I think mainly because it can you can deliver much higher pressure. I mean, you are talking about PEEP of 10, 12, 14 with the helmet, which high flow doesn't give you this positive pressure at all. High flow can give you maybe 2-3 centimeters of water. Face BiPAP can give you higher pressure, but at the expense of patient discomfort. Typically doesn't give you this high pressure either.
There is another question here. You mentioned that we're able to use higher PEEP on helmet opposite to regular NIV modality. Wouldn't we concern about gastric distension?
Yeah, we have not seen much of that. I mean, these patients are fully awake. So these are not patient comatose. These are fully awake, usually sitting or semi-sitting position. Most patients do not need nasogastric tube, by the way. So most of them, so in fact, you can feed them through a straw. So we have not seen much gastric distension.
Thank you, Dr. Yassin, as presentation as usual. Can we do proning and helmet together? And would you think this is an additive effect?
Yeah, I believe so. People find it a little cumbersome to do it, but we have done it in some patients, and I think it is of additive benefit because when you put the patient prone, and then you give the PEEP, maybe you'll recruit some of the dependent parts of the lung better. So the answer, I think it's a good idea.
What is the accepted pressure, a big pressure, to avoid barotrauma, depending on your practice?
Excellent question. So barotrauma can happen with helmet. Okay, so I have to say this is important because you are giving high pressure. It's almost like it's really giving almost mechanical ventilation, but without the tube. So some patients can develop barotrauma. In our trial, we follow the protocol that once published in JAMA, which has a maximum driving pressure plus PEEP of 30 centimeter of water. So we do not exceed 30 maximum. Although we have a data safety monitoring board, including some ward experts, Stefano Nava and Nicholas Hill, and some people believe that you can give more. But I think for safety, we decided that not to exceed 30.
Again, another question in the same line of your parameter. What is the best PEEP for FI2 flow helmet in your experience?
Most patients will do okay between 10, 12.
And the flow?
Flow above 50. Is it above 50 to 100?
The best practice, they're asking about best practice in your experience. So the PEEP is 10 to 12,
yes,
and the flow above 50.
Correct.
Well, by the time they're preparing question, you may allow a prof to ask you a question. In reviewing the literature of helmets, sir, did you come across in particular patient like asthmatic and COPD, do they do boards better or no change?
I did not. I think it's helmet. What I've seen is mainly used for hypoxemic respiratory failure. We will be not including patients who have airway obstructive disease such as asthma or COPD or chronic COPD in our trial. So for our trial, we're trying to have mainly acute hypoxemic respiratory failure. For COPD, typically you don't need this much PEEP.
Sure.
So the face mask probably is just enough.
So I wonder during the literature review, sir, did you come across any of those subgroup analysis of those obstructive airway disease patients?
No, I have not seen it. I did not come across this.
So I think there is a similar question. There is another question from Mr. Hussam. Excellent talk as usual. Many thanks. How much flow rate is needed to clear the helmet dead space in case using as a case of CPAP with PEEP valve?
So the dynamics.
Two type of the CPAP technique plus the PEEP valve. So how much flow rate is needed to clear the helmet dead space in case of using CPAP with PEEP?
Excellent question. So the helmet is a contained space placed around the head.
Yes.
So it can potentially cause CO2 rebreathing. So this is the problem.
Yes, indeed.
So when you use it for CPAP using oxygen flow, there is detailed protocols that are available online. But at least you need to give 50 liters per minute to wash the CO2. Okay, so it's really not small amount of flow. You cannot give 5 liters, or it will just retain CO2. So you have to give high flow.
Sorry.
For the ventilator, you cannot put the patient on CPAP. So you cannot connect the patient on CPAP without pressure support because he will retain CO2 immediately. You need to create a flow. And you need also to have a flow more than 50 liters per minute to wash the CO2.
The last question, if you don't mind, what are the targeted tidal volume and minute ventilation with helmet?
That's a very good question.
Yeah.
So that's an outstanding question, actually. So just I want you to think about the picture I put there, where you have the tubes connected to the helmet, and the helmet is, at least the one we are using, is not rigid. It's kind of plastic. So the tidal volume on the ventilator can be very misleading. In fact, it is almost impossible to monitor tidal volume. The tidal volume you will be seeing is the tidal volume within the helmet. So it can be 1,000, 1,500 sometimes, but it simply doesn't reflect what's happening in the lungs. You need to go simply by looking at the flow and rely on oxygenation and blood gases. But measurement of tidal volume through the ventilator is not reliable. And you should not lower your pressure support because the tidal volume looks high. So if you have a tidal volume of 1,000, do not lower the pressure support, because then you'll retain CO2. This tidal volume is tidal volume of ventilating the helmet, is not what's going to the lung necessarily.
So you do monitor them with frequent ABG?
Not very frequent, but yeah, we do ABGs maybe 2-3 times. I mean, these patients are awake, you have saturation, you have respiratory rate. So we do blood gases maybe 2 times, 3 times per day, and based on the clinical needs, but not very frequent.
Thank you very much, Professor. We really very much enjoyed the idea, and hopefully good luck in your research. And we very much appreciate your support to us. And we're very happy to have you again with us at the next presentation. Jazakallah khair, Doctor, and thank you very much.
Shukran jazeelan.
So it's an honor for me to present the second speaker, which is we'll be talking about the global practice of ventilator support management for patients with COVID. The speaker is Mr. Jabir Al-Qahtani. He is a lecturer for Respiratory Care Department, Prince Sultan Military College of Health Sciences. He's a vast expert in the field of respiratory care. He has a Best Research Award, mashallah, in Prince Sultan Medical Research Center in 2020, and highly cited research awarded in Prince Sultan Medical City Health Center in 2020. He's going to talk to us about something which is very important, which is the practice globally of ventilator support management for the COVID patient. Mr. Jabir, the floor is yours in this coming 20 minutes. Fadda.
Hi, everyone. Thank you so much, Dr. Hatton, for this introduction. I really thank you, and thank everyone contributing in this webinar. So basically today I'm going to talk about global practices of ventilator support management in COVID-19 patient. So this is published research that we had already published in the late of 2020 about this topic. I have nothing to disclose before I start this presentation. So the presentation content, I will talk about a very quick brief background about COVID-19. Then I will talk about rationale and objective of this study, methods, results, and highlights came from this study, and conclusion at the end. So basically, we know that COVID-19, we already talk about COVID-19, heavily, and we know that it's still, evolving, and we have now at least, more than 3 new variants of COVID-19. So this pandemic actually is really causing a huge burden on healthcare services and community. And as we can see here, this increased the mortality up to at least with 2 million people with COVID-19. Also, when we compare it with other previous pandemic, we can see that it can cause increasing in the mortality higher than other pandemic, except the Spanish flu, and we are in the second year now of this pandemic. So I think we are so lucky that we have the vaccination as soon as possible because of this pandemic, and hopefully that will decrease the cases. According to WHO, as you can see, the severity of COVID-19 so far, it's from mild to moderate, like 80%, severe cases 15%, and critical cases 5%. So basically, those from severe to critical care, they need oxygenation support, and they start to have escalation in the management. So later on, late of March 2020, the Society of Critical Care Medicine and the European Society of Intensive Care, they came out actually with a great sensible guidelines concerning, management of COVID-19 with different, areas. However, today I'm gonna concentrate on the recommendations with ventilator support. As we can see that they start with those who need, hypoxemia, they have escalation. So probably give them oxygen. If not, try high flow nasal cannula. If that's not tolerable, if not available, you try non-invasive. If not effective, you need to intubate that patient. And we have a complementary things with those with severe cases or critical cases. As we can see, we have COVID-19 with mild cases. Usually you give them like 4 to 8, protective lung strategy. You try conservative fluids and you keep their saturation high a little bit from 92 to 96. Those with moderate to severe, you start to consider high PEEP. You start to consider, neuromuscular blocking agent, traditional recruitment maneuver, prompt positioning, and short course of systemic corticosteroid. Those with a very severe or refractory hypoxemia, they need to have like ECMO. So these guidelines actually started to the idea of this project. So we need to understand at this time, like we have done this project in the mid of 2020. So we need to understand what people are really doing during COVID-19 in terms of ventilation, in terms of ventilator support. We need to understand that from, the clinicians, frontline clinicians, whether anyone dealing with ventilation support. And we know that by heart. We have here in Saudi Arabia example, we have respiratory therapists, we have sometimes intensivists, sometimes nurses, and even globally, we have different, practitioners like physiotherapists, the UK or in Europe or in South America. We have respiratory therapists outside. Even the pulmonologist can deal with this. So the rationale for this study, as I mentioned before, is just to know, explore the current practice that we have found, and also to highlight the challenges, limitations, barriers of healthcare providers dealing with COVID-19 patients to develop potentially, recommendations. So the methodology, we came up actually with international survey. It's been validated by, for content and face validity by international experts panel, including, those who are really dealing with those patients like pulmonologists, intensivists, respiratory therapists, physiotherapists, and nurses. We carried out this survey from 15th of April to June 15th. It was like a multidisciplinary perspective. We have international, representatives from different countries to validate, the results. We have distributed via, international, societies like, Canadian Society and Saudi Society. We have also distributed through the World Confederation for Physical, Therapy, also International Council for Respiratory Care. It's been distributed to many societies through their official, channel. The outcome or that we are looking for is, first one is just to look for the demographic data about dislocation experience training with mechanical ventilation. The second thing, which is about, the general management, starting from diagnostic tool used, type of ventilation modality used, different ventilation strategies and barriers and limitations. The result, we received like 502 responders from 40 countries across 6 continents, mean out of the ICU 64 with ups and downs 84. And we can see that the highest responses came from those countries that hit heavily by COVID-19, starting from Brazil, Italy, Saudi Arabia, India, United Kingdom, Turkey, United States, and the rest of that. So based on this, we tried just to do our analysis based on the continent itself. So we split our those countries, those responses from these countries to 6 continents, from Africa, Asia, Europe, North America, Oceania, South America. And we can see that we have lots of responses from Asia, Europe, North America, and South America. Actually, Africa, we didn't receive a good responses from Africa. And we know at that time, the number of COVID-19 cases in Africa was very low comparing with other, countries around the globe. And we can see here from this figure the qualifications based on those responders. We divided them to diploma with the blue one and bachelor degree, master degree, PhD degree, according to those continent. And we found that Asia has bachelor and diploma the highest. After that, coming Europe. We can see that those with postgraduate degrees are mainly came from Europe, which is expected because they have more interest in education, especially in the clinic wise. South America, we can see equal distributions. And we can see those people who are dealing with COVID-19 during with ventilation. I mean, during COVID-19, respiratory therapist, we have physiotherapists, we have ICU intensivist, pulmonologist, anesthesiologist, and nurses. So those who are dealing with COVID-19 ventilation. When we go to type of hospitals, as we can see here, we have good responses from tertiary hospitals. And in terms of hospital beds, we have like most of the responses from those hospitals with 200 to almost 500 beds. And we can see here the previous training in mechanical ventilation. We have defined this based on at least 6 weeks of theoretical and practical sessions of mechanical ventilation. We found that only 85% having training. The rest, which is 15%, they don't have prior training. This is actually shockable, maybe because of the deployment of those employment to this job. It's really unjustifiable. Those who are really dealing with this serious, intervention, and they don't train of this. We can see that, those with lower experience were, mostly reported from to almost 30%. Also, we can see here the training in mechanical ventilation, mainly those who are trained came from Asia, Europe, South America, comparing with the rest of the continent. And we go now to the most important thing, which is the clinical ventilatory management of COVID patients, starting from diagnostic or tool to initiate therapy. We can see here those patients or those clinicians, they make their judgment directly based on the ABG, followed by clinical presentation. No one actually use chest imaging and clinical presentation and ABG to make a judgment. I mean, it's only 6.2. Mostly depend on the ABG, which makes sense. Available protocols, we can see here only, most of them, especially high flow nasal cannula, non-invasive ventilation, they don't have protocols. At least half of the responders, so they are using it, but they don't have protocols, which is, increasing, the problem and complicating the issue, because some of the clinicians, they don't have training and they are using it without protocols. So it's really a little bit, questionable. When we go to the guidelines, we can see the most of them, they prefer to use their national and their own practice, comparing with WHO. So the WHO and critical care medicine are really used a lot after using, their practice. So that's indicate isolation from the global guidelines. Also, when we go to initial ventilatory strategy, we can see that we have mild, moderate, severe. We can see those with mild cases. They use with them like high flow nasal cannula. We have defined, the severity based on Perlin law, and we can see people prefer to use high flow nasal cannula with mild cases. Moderate cases, they start with non-invasive, then they go directly to invasive mechanical ventilation instead of high flow nasal cannula. Severe cases, most of them go to invasive, but some of them, they try to give a go with non-invasive, maybe high flow nasal cannula. We go now to something really interesting about, the monitoring itself. We can find that ventilator system checkup, which is time interval to monitor the ventilator, was like as needed from those clinicians. This is okay, could be justifiable, but still, if you don't monitor them, with consistent time, maybe further complications will happen, like ventilator asynchrony, like, ventilator associated pneumonia. Maybe that can complicate, the case itself and make it, worse. So it's really important to have standardized, time interval to monitor your ventilator. We go now to the second thing, which is about initial flow settings of high flow nasal cannula. We can see that most of the people, they prefer the starting flow from 30 to 45 liters per minute. And according to the recommendations, it's only one recommendations I found it from Australian guidelines about that, which is they recommended to keep it below 30 because they believe it decreased the dispersion of aerosol. Also, the non-invasive modes, we can see here CPAP, it's used a lot, which is indicate, the severity of those patients in terms of oxygenation. Also, when we go to interfaces of non-invasive ventilation, we can see full face masks are used a lot, mostly, and helmet, they used, only in 13% they use a helmet, and this is justifiable because of the resources and because of the training. It needs lots of training, but still it can be effective as others mentioned. When we go to invasive procedures or invasive mechanical ventilation modes, we can see that volume control are mostly common used mode, following by pressure control mode, which is okay, it's fine, because we know that volume control, it's been used in the ERDS net, and it can be used to precise that we have delivering, the right, tidal volume to the patient. When we move to the ventilator strategy used, we can see that low tidal volume ventilation being used a lot from 96, and use of prone positioning with helmet. We can see that it's used a lot. It's like 85% of the clinician, they used proning, and usually the proning will be like from 12 to 16 hours per day, which is according to the recommendations from the critical care guidelines. Also, we can see the reasons for not proning. One of these reasons is having, no training on this. So we need to have a training in order to do that. We can see that tried awake proning, those who tried awake proning in combination with high flow nasal cannula or non-invasive ventilation. It's around like 46.2% of the clinician, they tried awake proning. And, the interesting bit about this, there is no evidence, still uncertain, and people prefer to use it. Okay, it could be justifiable, but I didn't know actually why it's almost half of the responders from different, countries, they use it and they believe it can be affected. And we know that it may be just transient, improvement. After the proning, this will go. Nitric oxide, we can see it's 38% used. We can see something important here about recruitment maneuver. When we compare the stepwise PEEP adjustment, which is ascending or descending PEEP, with inspiratory hold, with the traditional one, the recommended one, we can see people used, the stepwise PEEP adjustment. This is really increasing based on the evidence, increasing the mortality comparing with inspiratory hold. So people, they are working outside the guidelines and they are treating their patient by they increasing their mortality by using something. There is no justification for it based on evidence. When we go to the limitations, which is the last bit of this presentation, is just to show that when we see the right figure, which is the blue one, we can see that increased staff workload, lack of trained staff, shortage of PPE, shortage of staff, shortage of ICUs are the mostly common, barriers or limitations during COVID-19 patients when you treat those patients in terms of ventilation. We can see that comorbidity, lack of protocols, policies are really affecting, the management. We did actually do it per continent, and we see that lack of trained staff are, reported, heavily in Asia and Europe and even South America. And when we go to increase the staff workload, we can see that, again, it's in Asia, Europe, South America. Also, the interesting thing about lack of protocols and policies, because all these, limitations are modifiable and can be readjusted again. So lack of protocol and policies, we can see Asia, followed by South America. They have a very limited or protocols available to treat those patients, comparing with other things. The other interesting bit here, which is about the interminable meeting, which is long meetings. We found that it's increased a lot in Europe, followed by Asia, South America. So they think that, and I saw like a RCT that telling that those who having, interminable meeting or long meeting can lead to, complicate the COVID-19, outcomes. And I think it's published in New England. Highlights of this study, of this global study. This is the first report to globally, explore the current practice and barriers encountered by healthcare providers. We found that intensivist has the longest professional experience, more than 20 years. We found that the general clinical practice lack uniformity, and those with less 5 years experience were mostly respiratory therapists. Limited use of standard protocols. We found that 72 or almost 73% were from tertiary hospitals, in which identified the highest percentage of diploma. So according to WHO, it's not recommended, or it's recommended to have highest degree effort to work in tertiary hospitals, at least minimum with bachelor degree. And most of those, they are working in tertiary hospitals with diploma. Most healthcare workers work outside the general treatment guidelines, and we can see that high flow nasal cannula and non-invasive used frequently, despite limited protocols for that treatment. 15 of the responders with no mechanical ventilation training. This is, need to be considered in the future. 46 of the responders attempt awake pronation, and still, the effectiveness is uncertain. And according to the update from recent update from critical care guidelines, they couldn't do any recommendations because of lack of evidence. The majority of responders didn't adhere to the recommended regular ventilatory check interval. So this is very important, need to be considered. We need to have time specific time interval to monitor our patient while they are on the ventilators. The other things, which is the majority of the critical care providers used stepwise PEEP adjustment comparing to the recommended traditional method in respiratory hold. And we know that this increased mortality and people are still using it. So it's very important to follow the guidelines to make sure that you are up to the point, up to the date with this evidence. More than half of the critical care had used systematic corticosteroids, which indicate increased severity accompanied by ERDs. Generally, these limitations are modifiable, so we can work on this and can modify it. Even we are now starting in the second wave of COVID-19, so we can change a lot about this. Increased workload to staff ratio increase the mortality rate of critically ill patients. One of the major factors or limitations in this study is that increased workload. So,
2 minutes.
Yeah. So this will increase, the burnout and maybe will lead to increased mortality. Again, it highlights the strength and limitation encountered by healthcare providers. So finally, future research should focus on producing a clear integrated guidelines from multidisciplinary teams, including, multi-countries, in order to address these limitations and barriers. Conclusion, our data from 40 countries across 6 continents present the first report on clinical fertility support. It shows that high heterogeneity with limited use of standard protocols, mostly isolated and depending on valid guidelines. Major limitations, increased staff workload, lack of trained, shortage of PPE, shortage of staff, shortage of ICU beds. Thank you so much. Just to mention that definitely this study has limitations, plenty of limitations, but we were so lucky that we received this response during COVID-19, and still this is something really good. at least we have something and we add something to the literature as exploration for the current practice. Thank you so much for everyone, and I'm happy to receive any questions.
Jazakallah khair, Mr. Jabir. It was an excellent. I have one suggestion and one question, if you don't mind, by the time we get the question. Since alhamdulillah, we have this Saudi Critical Care Society and we have this Saudi Society of Respiratory Care, wouldn't it be nice also to circulate such validated, excellent questionnaire at the level of the kingdom? Mind you, as Dr. Shahrani mentioned, I'm sure this is all over the kingdom, not only in the Eastern region here, that if the people early get it for February, March, April, May, we here in the kingdom, we get the storm, I can use this word, July, August, September. So we have a good 4 months now after the big storm and the big start to come down. It might be useful if you circulate it over the kingdom through the, the chapters of the Respiratory Care Society. They might help you to find out, are we comparable in the profession, at least in the setup of the hospital, the credential of the people taking care of the ventilated cases, and then you may come up with another meeting after, let's say, after 3-6 months to discuss that, can we standardize the care during pandemic in general? Because this is a good challenge, not only to the kingdom, but to the whole world, that we should be prepared for the future for another pandemic and where we can. So this, I believe, subhanallah, that the pandemic of corona came with a lot of positive challenge to everybody, not only to the health services, but all the people. So among us as healthcare professionals, might be some kind of questionnaire might give you an impact of a percussion, what's going on over the kingdom. Did you think of it?
Definitely, actually. I really appreciate this comment. It's really important to have, a nationally, a thing like this, just to explore that. Actually, we are working on the responders that we have received from Saudi Arabia, and we try just to figure out if those are comparable with the global practice or not. But actually, it's really a great idea just to have a collaboration from different including intensivist, respiratory therapist, physiotherapist, nurses, anyone really dealing with COVID-19 ventilation, just to distribute another survey, just to evaluate that after producing the updated guidelines from critical care society and other guidelines, just to compare it with the previous way first wave of COVID-19. Actually, totally agree with you, and we don't mind just to do that, but we need to contact the people who can distribute and can help us in this.
I think your way targeting the Saudi Society of Respiratory Care might be a good door to knock, and that might be a good idea to start with. I have a question for you here. Do you think future studies regarding the same topics will have noticeable changes on the result, whether the positive or negative manner on the practice? This is a question from somebody saying, do you think future study regarding the same topics will have noticeable changes in the result, whether in positive or negative manner?
Actually, the answer is unknown, to be honest, but I think I do believe there will be a change, whether positive or negative. But I think mostly positive, because people now getting to know more about COVID-19 and how to decrease the burden of COVID-19. Lots of guidelines being already published about this topic, and people now start to think about their practice, because at the beginning of the first wave, we know that lots of practices having increased surge in ICUs and ventilatory uses, and lots of patients came to the ICUs, so maybe they are not really doing it up to the optimal level. But I think if we do it again, we will find something positive more than this.
I totally agree. In fact, if a lesson we learn, the first hit when it comes to Italy, you can see the chaos they survive. And then 6 weeks after the chaos in Italy, you see the NIH or the British guidelines start to come up, and they start to do the preparedness for the pandemic and take on and so forth. And I've come across the nice preparation guidelines coming from the ARC, the American Association of Respiratory Care, where they really put the guidelines of using nebulization and invasive ventilation. Even though at that time WHO were talking about, is it triplet, is it really aerosol, and so on and so forth. I think will definitely change, positive or negative, and the attitude. And probably with after 1 year experience as healthcare provider now, we have no excuse not really to explore whatever good or bad experience, because at any situation in the world, there is nothing called bad experience. There's experience to learn and build up on it. I think this is the last question I have. And if there is no more question, if you allow me to ask you just one practical question. Now, at least in the region of Riyadh, were you able at the 3 big hospital or 4 big hospital in Riyadh to come up with the standard ventilatory setting in COVID patient? Because mind you, in early crisis, every one of you knows that the mechanism of ARDS COVID is different. This is why they call it CART to start with, and they get to know his stories about the what they call the cytokine storms and the effect of the lung. So, are you aware of any setup near to you where they are using a standardized of ventilator in COVID patient? Start with from your hospital.
Actually, I'm not the right person to ask me the question, Dr. Hatem, because I'm not currently now in Saudi Arabia, so I don't know exactly what happened there.
Oh, I see.
In terms of having standardized protocol, but I think it's gonna be like great opportunity for everyone just to have a standardized thing. But we need first to have certain guidelines coming from Saudi. I think there is one, but we need to have it from multidisciplinary teams, including respiratory therapists, intensivists, and other teams, to have a very comprehensive one. Everyone can stick to this guideline.
Thank you very much, all the participants. Thank you for an excellent survey, and I hope we can carry it on in the kingdom. It's last and not the least of our presentation. This is a talk which is going to be presented by our sponsor, Kemal Al Jazeera. I'm happy and honored to present Dr. Robbie Person. He is the Vice President and Worldwide Forced Oscillator Technique, FO2 and Asthma Management and Business Development of MJC Diagnostic. He's a prominent international expert, and he's a speaker in the field of respiratory diagnostic, marketing, and clinical application, as well as device design and development. In conjunction with him also, I'm glad also to present the second partner of him is Dr. Shahid Mir. He's an MD respiratory therapy, clinical specialist and product manager at Kemal Al Jazeera, which is our sponsor for the conference, which is, we very much appreciate their support to the conference. He's an expert in the field of respiratory diagnostic marketing and the clinical application, as well as device installation and training on the indoors. They're going to talk to us about the use of the Resman Brew FOT, and the floor is yours, Dr. Ruby. Dr. Ruby?
Thank you very much. Yes, thank you very much. This is Dr. Shahid, and Dr. Rabi is there also with me. Sure. Thanks for your, the time giving us, and thanks for Robbie also. He's joining us from Rome, and I think
Milan.
So how is Milan now?
It's beautiful weather. It's the beginning of the spring, guys. Very nice.
Then we'll hear from you also. Please, Doctor. If you can start.
Yes. I will now start sharing. This is a. I promise I will stay into the 20 minutes slot that I was allowed. Can you see the screen now?
Yes, clear. Good. And your voice is loud and clear. Thank you.
Fantastic. Well, I'm in a music studio, in a soundproof studio with fantastic isolation. So I wanted to give my little contribution to the COVID-19 difficult times that we are all experiencing. By talking about, this is a very short version of a long presentation that I give around the world. And I actually had the pleasure to come to Saudi a couple of years ago for a week and present this several times. It's called demystifying or making easy a subject that is normally perceived to be rather complicated, or at least requiring a deep knowledge of physiology. So what I'm going to talk about it today is using this technique, oscillometry or forced oscillatory technique, during these COVID-19 times. So before I get into the second part of the presentation about specifically why it's so useful, let me give you a very short version of what I discuss and how I describe how is forced oscillatory technique. And let me start with how the test is performed. It's simply a test that requires 10 tidal breaths to obtain the same information that we get with 3 good forced repeatable spirometries. So we will get information about peripheral, central, or large airways obstruction from children to adults, all in 10 breaths. So you can see that the patient breathes normally. This is the old model actually, but it really gives you an idea. I like to start from the end of the presentation and telling and showing you how the test is done. The patient coughs or the patient closes the glottis or anything, and the system automatically stops the count, rejects the bad breaths, and stops at 10 accepted breaths. So it is not a new technique. It's a technique from the 50s. It's called forced oscillatory technique, not because the patient needs to be forced to do something, but because we force in the patient airways some acoustic waveforms. And the waveforms are generated by a large loudspeaker that you see here. The technique was originally developed to overcome the inevitable problems of the gold standard. I mean, you won't believe this, but this has been done for 140 years. We've been doing forced spirometry, forcing the patient to collapse the airways, blowing, to understand if there is an obstruction. Also, this maneuver involves a deep inhalation, which obviously, as many of you involved in asthma, is pretty sensitive to the respiratory muscles. So the dream of every respiratory allergist is to have a test to do pre and post bronchodilator that doesn't require the deep inspiration. It's also a maneuver that requires a forced maneuver. So this is exactly what happens when you breathe normally in an oscillometer. There is a lot of little tiny oscillation, acoustic waveforms that overlay your normal, I repeat, respiratory cycle. These oscillations travel, these waveforms travel in the lung all the way to the small airways, return, and we actually analyze what is the signal that returns. What are the 2 parameters? Very simple: resistance and reactance of the respiratory system. Resistance is very easy because we do it not great, but we do it somehow with the body box. You know, you remember in the pulmonology department, there is a body box. Body box is the gold standard for lung volumes, and it will always be that way. It's not really been built for resistance measurement. It's also, you know, the patient needs to have a certain breathing pattern, but resistance, it's actually equivalent, measured by a forced oscillation technique, to FEV1. So it's really the more central component of the obstruction. Reactance, on the other hand, it gets pretty interesting, because if you ask a pulmonary physiology what pulmonary reactance is, you will be here for about half an hour, because they will go into very complex mathematical models, tangents, intersection. Well, reactance is really how well air reaches and ventilates the very peripheral airways. So if resistance is equivalent to FEV1, which is the paramount parameter, reactance is actually equivalent to FEF 50/75. So it's really the small airways, the mechanical properties and the efficiency of the small airways, which, if you remember, is the least reproducible parameter in a spirometry. You know, take a deep breath, blah, 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 keep blowing, keep blowing, keep blowing, keep blowing, keep blowing, keep blowing. Well, that is reactance. So it's FEF 50 and 75. And as the FEF 50, 75 goes below the predicted value, the same thing is for reactance when you have peripheral obstruction, tidal expiratory flow limitation, alveolar gas trapping, or also large patients, obese patients, neuromuscular patients. The first thing that goes below the predicted value is the function of the small airways. So the two most important parameters are resistance and reactance, measured at the lowest possible frequency, which we can measure with the oscillometry. And this is a statement from the European Respiratory Society. This is the third parameter, which I'm going to surprise you now, because the third parameter, not only resistance and reactance, is something very exquisite in pulmonary physiology. This is how the lung moves, how the respiratory system works. Simplified, the diaphragm pulls, generates a negative pressure in the thorax. The airways stay open, inhalation, exhalation during tidal breathing, and during inspiration, the negative pressure ensures that the small airways are all kept open because of, it's like having a lot of little balloons, popping open balloons. During expiration, however, in disease state, the inflammation, the mucus, the secretions makes it so that the very small airways, which are, as you know, extremely small in terms of size, they don't reopen because of the positive pressure. So that what is called the choke points and make it so that the oscillations, so these waveforms that go in and out, don't reach the small airways. So even if we thought for many years that the most sensitive parameter to measure an obstruction is the expiratory forced side, it's not so. The most sensitive parameter is the inspiratory, because everything is open. So we've proven these 10 years ago with experimental systems that, for example, looking at the total resistance before and after a bronchodilator sees no change, because the total resistance, remember that the total parameter includes the expiration, but when you look at inspiratory before and after a treatment, that's where the truth lies. So to conclude the parameters, we can measure a very important parameter, which is called tidal expiratory flow limitation, which is a patented parameter from the Politecnico of Milan. This device was designed in Italy by the important school of the Politecnico Biomedical Engineering School in Milan, and that's why I'm here. And the difference between the inspired and expired reactants, so the small airways, make it so that we can see if the patient is breathing at tidal volume, and if we could do an expiratory maneuver, the expiratory force maneuver would touch the tidal breathing. That's why these patients are the ones that you see with a stroller in your departments, and they cannot climb stairs or walk fast. So, and those are the patients that actually, in order to defend themselves from the flow limitation, hyperinflate. So increase their volume, their tidal volume, and they go at higher tidal volumes. So this is a schematic representation of what happens when the airways are healthy, or when the airways are not healthy, then the expiratory side, even at tidal volume, is impaired. And if you could do a maximum flow, that would touch the tidal volume. So we have patented an index called the expiratory flow limitation, which is nothing else than the difference between expiratory and inspiratory reactance at the lowest possible frequency. And we represent it as a graph or as a number. So this is a good outcome for pulmonary rehabilitation or for treatment of COPD or severe asthmatics. If you are at 100% flow limited, 10 of your breaths are all flow limited. If you manage to decrease it to 75%, hats off. So another thing happens, another interesting phenomena happen, that the tidal volume goes up, so the FRC level goes higher, and therefore the residual volume goes higher, and therefore the inspiratory capacity is smaller, because these patients are inflating like balloons. They are hyperinflating. That's why with this device, we can also do the simple maneuver of slow vital capacity in order to evaluate not really the vital capacity, which is interesting, maybe to evaluate restriction, but the important thing is to evaluate the inspiratory capacity changes, because that means that you are treating your patient. Here, look at this, 30% decrease in inspiratory capacity, increase in inspiratory capacity means that your treatment is successful. So a good review that Shahid Mir, Dr. Mir will be able to send you, or I will be able to send you, is the a good summary, non-invasive screening of expiratory flow limitation in COPD that summarizes in 3 pages the all concepts. So the good news is that FOT is getting more popular. Although it's a technique from the 50s and it was used as research, now is a true, complete clinical measurement that you do every day on every patient. And the ERS has published in September a very good summary that says that the EFL, expiratory flow limitation, is a good patient because it shows a good parameter, because it will show you the values and the capacity, the functional capacity of the patient. And the clinicians are now growing more familiar with this terminology, and it's becoming medical part of the medical practice. So the 3 big applications that oscillometry is used, especially with Resmond: COPD, asthma, and evaluation of airways clearance. So physiotherapy, when one of your physiotherapists does a pre and post 30 minutes treatment, well, that is really releasing, opening up from an obstruction. So we actually can, when doing 10 breaths, in those 10 tidal breaths, we can actually evaluate the effectiveness of physiotherapy, which is normally now relying on a subjective feedback. You're asking Mr. Jones if he's breathing better or not. So it's in pulmonary departments, pediatric departments, respiratory, neurorehabilitation, thoracic surgery, allergy, occupational medicine, where patients don't want to do a good spirometry, and cystic fibrosis, COPD, asthma, airway clearance. In asthma, it's used in combination with exhaled nitric oxide, because they are both markers of inflammation and obstruction before the symptoms appear or the spirometry shows a decline. And it's also a very interesting medication control, both parameters, because the patient comes back and you now notice that after a year, and you see him every 6 months or 3 months, you see that the values start going up. So you ask, what's going on? And the patient will reply the natural answer, which is, oh, doctor, I thought, I was feeling better. I thought that you treated me, you cured me. So I'm not taking the medication anymore, which is wrong. So you can use it to evaluate the treatment. It is also used widely around the world at the bedside. So it's now that you understand that we're doing something very similar to forced spirometry, but with 10 tidal breaths, now you can see that we can do it in any position, in any setting. So we use it in COPD, in rehabilitation, in sleep, to see if what is the best position that makes the patient breathe better, and so on. So we evaluate after the test of the 10 breaths if there is a peripheral obstruction, if there is a central obstruction, if there is a severe obstruction, asthma or COPD. And that again is with the 2 parameters, resistance and reactance, central or peripheral. And we can go, anybody interested can contact Shahid Mir, and we can plan one of my webinars, 30-60 minutes, where I can go through the whole thing, including examples. We also developed an evaluation poster translated in 7 languages that helps the operator to quickly understand what they're doing. So let's now conclude the last 5 minutes with how Why is this now growing so popular in COVID? Well, with what I said earlier, it doesn't require forced effort, but just a tidal breathing maneuver. So we reduce the fear. Everybody in the world has this fear. Oh my God, forced spirometry, all these droplets, all this forced maneuver flying around the room. Well, with FOT, you don't require a forced effort. So the risk is really minimum, and it allows you to identify the presence of obstruction, but also to localize it. So with 10 breaths, think about that, 10 breaths, you will know if the patient has a small airways disease, a small airways obstruction, central airways, large airways, without a forced spirometry. And it is safe. In Italy and France, there are several departments now doing tests on post-COVID patient. It's very interesting because you could use it with COVID patients, but most important is with people who are recovered from COVID, because there are some interesting landmarks, features in post-COVID patients that we are able to pick up very, very nicely. So this is now being used for the first evaluation and for the follow-up of the progression of the disease, looking at the lung recruitment, the flow limitation, the small airways, because small airways is where COVID hits right away, and we can look at it. So here we solve some issues. Number one, safety. The potential for coughing and droplet formation surrounding pulmonary function testing procedure is there, and Resmond is a fast, normal tidal breathing procedure. The second issue is it is very difficult to screen patients who don't have COVID, because everybody, around the world, pulmonary labs have been, either closing or limiting their tests. They have to clean the room after every patient, open the windows, sterilize the equipment, and so on. Well, it is not a problem with Resmond because you can transport it within the hospital, and as well as it's very fast. It doesn't need a PC. It needs a antibacterial filter, the same one that we use for spirometry. The only difference is now you must pretend from the filter manufacturer that they give you a letter, and there are several that give you a statement of their testing. There are a few things that we know well about COVID. One of them is the size of the particle. So a lot of these filters have been tested for particles much smaller than COVID with success. So 4 to 8 times smaller than COVID and at very high flows. So when a filter manufacturer gives you an efficiency of 99.9%, you can trust it. And there are several manufacturers that will give you this. The operator, because the tester, the Resmond is automatic, starts and stops automatically. The operator stands back. It doesn't need, like in spirometry, to stand next to the patient or in front of the patient. No, the operator stands back. There is very little contact between the operator and the patient, so the confidence level is very high. The system, as I said, accepts 10 breaths. At the 10th breath, you actually go with your USB key, take the results, go in another room to read and interpret the result. Because the device doesn't use a PC, you don't need to clean or to sterilize keyboard, extra screen, nothing. Just wipe the Resmond, which is approved by the FDA and CE guidelines with cleaning procedure, and you are good to go. There are several articles now that came out, which obviously confirm a lot of them are using Resmond and our Pheno devices, that tells you that the Resmond stores on a pen drive, so the operator can go outside the lab. The operator can be placed behind the child. There is no dispersion of particles in the room, infection control advantages. All of these you can get in a PDF format. If you request to Shahid Mia, I will be able to send you all of this so you can read it with time, because I'm almost finished. You can also do methacholine or other challenge studies. This is a fantastic center in New Delhi that does thousands of patients every year, that actually had used the Resmond for testing as a safer alternative to lung function, no increased aerosol generation. Other papers also, they say the same thing. Tidal breathing is safer. And now we can give you the same parameter as the spirometry without spirometry. So again, you will be able to read that with time. I'm into the 20 minutes. So to end, we can measure in COVID times lung recruitment in small airways. Remember the reactants, the small airways, that's what we give you. All the respiratory pattern parameters, so we can see how the patient is breathing, and the important tidal expiratory flow limitation, which obviously in a COVID patient is increased. Then we can do the slow vital capacity to look at hyperinsufflation. And the two uses are, number one, in all pulmonary patients that have symptoms and diseases unrelated who need to be tested. You know, in Europe, for 6 months, we had a long waiting line of COPD in asthmatics, adult and pediatric, that actually could not be tested as fast and as much as in normal times. So this will allow you to restart your pulmonary function testing. The second category is all the COVID-19 patients who have recovered and need to be followed up every month or every 3 months with the same parameter that I described, plus diffusion capacity. And specifically, if you have membrane diffusion, even better, because it will give you the pulmonary capillary blood flow and the membrane diffusion. So that's with DLNO, diffusion with nitric oxide. So there are also centers now, the worst is over, that have been using Resmond in the ward, in the intensive care, just to make sure that they could measure the patient without having to auscultate him, because they were all fully dressed up. So there is today no safer tidal breathing pulmonary function test that can be performed during these times. So thank you very much. I am done in 1 minute delay.
Well, actually, you are. Thank you very much, Dr. Ruby. I'd like to thank also Team Al Jazeera for inviting you to be part of this very nice machine, which is, I think, it's coming way in the future, because nowadays, in coming 5 years, you're going to see a lot of literature talking about small airway disease, treatment, diagnosis, management, and also follow-up.
Exactly.
I have 2 questions from the audience, and then I have my own question to you. There is a question from Zahra said, there is any standard predicted value for oscillometry?
Yes, all of these tests, because remember, it's a 70 years old test. All of these tests, all of these parameters have predicted values for children to adults down to 2 years of age. That's how low you can go.
So the second question is for Mr. Hussein. What is the main difference between FOT and spirometer? We can detect an obstruction by spirometer.
This is actually a very good question. I have hidden that slide, but there are advantages and disadvantages. The only disadvantage currently for spirometry, and you can see the slide here, is that spirometry can classify the degree of the disease with the ratio between FEV1 and FVC. But spirometry does not really localize where the obstruction is. It tells you if it's mild, moderate, or severe, and FOT is superior. So to give you a little overview, we are already working in 3 major clinical studies, US and Europe, that in a couple of years, will actually be able to use oscillometry with the last drawback that now we have, which is we cannot right now give you the degree of the disease. But that's why you use them together if you can. So you do Resmon on every patient, and if possible, you do a spirometry. But then for the follow-up over time, it's much easier, more repeatable, easier for the patient, safer to do Resmon, or for the pre and post, because there are thresholds published, validated. The new guidelines, oscillometry guidelines, came out 6 months ago. So now there is a significant response for pre and post bronchodilator. So there are so many advantages.
Can I ask you this question? This is another question with the last, because only 1 minute left for us.
Yes.
Ms. Amal is asking, does the result get affected by the patient sitting position while performing the test?
No, not as much.
Was semi-recumbent, so with the position of the patient in general will affect the result?
No, not as much as in spirometry. The only drawback, the only enemy of this test is the neck. So this is the position that you can see that we recommend. The patient has to be seated normally, but the neck has to be more or less at 90 degrees, because of course you don't test obstruction with an underextended neck or with an overextended neck. But this is the very simple, as you can see on the slide, the very simple position. So the patient can be sitting, can be standing, can be laying down, can be, the only thing is, again, the neck has to be kept at about 90 degrees.
Thank you very much. It was very enjoyable. I would like to thank Kamal Al Jazeera, and I will keep the closing remark with our chairman, Dr. Noor Al Khaflan. Please, Dr. Noor, the floor is yours.
Thank you very much.
Thank you very much. Yeah.
Thank you very much all, and for you, Professor Hatem, for being the moderator tonight for this lengthy meeting. I would like to express my grateful and thanks for our distinguished speakers, yourself, Professor Hatem, for your unlimited support to us and Respiratory Care Department, and for all our participants for during this virtual forum, as well as the Dean of our sponsor, the Deanship of E-Learning and Distance Learning, headed by Dr. Amir Al-Mahashir, and the Vice Dean, Dr. Tariq Al-Khaldi, for their unlimited support, and the technical team, Ms. Noor Al-Bakr and Ms. Khadija Saeed and Ms. Raed Abu Rayash and Mr. Mohammed Al-Rashdan. And last but not least, my family, the RC department at IAU, for their unlimited support in preparing the scientific program and advertising it, especially the unknown and hidden soldier, Ms. Cynthia Navarroza. So thank you very much all for your efforts, and it's and looking forward for future conferences. And Dr. Hatem, the mic for you. Thank you very much.
Jazakallah khair, Doctora. Thank you. I'd like really, on behalf of the university, to thank all the speakers who really make this event very fruitful. I'd like also to extend my great gratitude and appreciation for the amazing job done by the Deanship of E-Learning and for their support, which is not really surprising. And I'm really biased, Dr. Noor, because I belong to your department, and they are my partner in all my career. So I'm sure the next few talk will be coming from, next conference will be coming from your department, and rest assured will be my honor to support you all through.
Thank you very much.
And hope to see you again, inshallah.
Thank you very much, our godfather, Professor Hatem. Thank you very much. Thanks a lot all. Goodbye.